Hello, everyone. We will begin at 1 o'clock. We have like another 45 seconds. Hello and welcome to Mayor Horrigan's 5th Annual Health Equity Summit. This year, as a result of COVID and the pandemic, we are going to do this virtual, and I appreciate everyone attending this summit in a virtual fashion. I'm going to turn it over to Mayor Horrigan right now. Thank you.
Well, good afternoon. Thank you, Tamika. I certainly wish that we could join together in person. I know everybody else is COVIDed out and Zoomed out on a lot of those things. I think there's so much more that you get by an in-person meeting, but I certainly understand and want to make sure people feel comfortable in being able to meet. Thanks again. I guess, like Tamika said, this is our 5th annual summit. And since taking office, trying to tackle the racial disparities in healthcare and finding equitable solutions to those who've been disenfranchised really has been a major focus of my administration. Last year, the city of Akron declared racism as a public health crisis. Not only did we see the disparities exacerbated by COVID and the pandemic, but we also saw how systemic racism impacts our daily lives and specifically causes harm to communities of color. Today, you will hear from experts about how systemic racism negatively impacts the health of minorities in all of our communities. And tomorrow, you will learn more about how systemic and institutional racism play an integral part of our behavioral health system and why it is stigmatized in the African-American community. The summit really is a chance to bring together the leading experts in healthcare and social work and policy to find those holistic solutions to benefit community members. And I want to thank all of the panelists and our sponsors and attendees for taking this time to come together. I'll turn it back over to our Health Equity Ambassador, Tamika, and I appreciate all of your support and all of your involvement in this summit.
Thank you, Mayor Horrigan. We truly appreciate your support in all of our efforts here. At this time, I'm going to turn the floor over to Ms. Judy Hill, President of the NAACP, as she facilitates a panel discussion around COVID. Thank you.
Thank you, Tamika. First, I would like to also thank the City of Akron Health Equity Committee for putting together this panel. I think it's important for us to discuss COVID-19 and its impact on mothers and children in general. We only have 45 minutes and it's a lot to cover. But before we do that, I just want to back up a moment and go over how this whole initiative got started. The mission of the First Birthday Greater Akron is to advocate for policies, educate the community, inform Greater Akron citizens of programs that promote healthy full-term pregnancies so children can have a first birthday. I think that's important for us to say every day, all the time, because if we don't know the mission, then any place will get us there. This conversation started because of disparities noted in a report in birth outcomes. Black infants were dying at a rate 3 times the rate of white infants. And because of that, Tamika Rose was hired and brought in to look at some of the inequities and how we can move the needle. So I applaud you, Tamika. I applaud the committee for putting together even a virtual conversation to talk about this initiative, to keep it moving so that we don't put it on the back burner. The Akron NAACP is a supporter of this initiative, and so I appreciate you inviting me to be a part of this conversation. So with that, we're going to get right into our panel. Tamika has done a wonderful job of putting together a group of awesome women who are making their mark in the Akron area to make sure that we don't forget about women and the inequities that we are discussing here today. I'd like to introduce first Donna Skota. She's from the Summit County Public Health. She's the commissioner. Thank you, Donna, for being a part of this. Dr. Angela Sims, Akron Children's Hospital. She's a pediatrician, and I believe she works out of Fair Lawn, Ohio. Dr. Jennifer Zavitsky, I haven't had a chance to meet you, but thank you for joining us. She works at Akron General Cleveland Clinic, gynecology, I believe. She's chair of that committee. And India Robertson, Birthing Beautiful Communities. She's the director of expansion and training. It's an organization that was formed in 2014, I believe, to help develop women, train them, certify them, and employ them in becoming doulas. And I believe the organization started in Cleveland, but I think has expanded. So with that, I'd like to start everyone off with a question, if that's okay. And I wish I could see all four panelists at once because this drives me crazy. I am also an individual that loves to meet people in person, but I'm glad to have this opportunity as well. So my first question is for each panelist to answer together, if it's okay. You just, whoever feels the need to answer first, please feel free. In 1 or 2 minutes, what I would like for you to do from your vantage point as a professional, how has COVID-19 in general impacted women, mothers, and children? Who would like to start?
I can start. Judy, thank you. I can go ahead and start because we've had about 21 months now of COVID and have certainly seen the impact. I think anytime there's a national crisis or any sort of shortage, or children suffer the greatest simply because they are the most vulnerable. You have young children that are vulnerable and you have older adults that are vulnerable. So I think for moms and babies and families struggling during COVID, it has been exponential. I mean, it's just been magnified, whether it was a shortage of food or unemployment, illness, death, caretaking. It just complicated everything for everyone. And then layer on top of that, if there were any existing disparities to begin with. You may have worked a job where you were on the front line. You couldn't take time off work. You may have had your children home from school when you were trying to homeschool. So I think what we saw was the perfect storm. And unfortunately, families, children, moms, dads, everyone paid the price because it is very difficult if there's any disparity to begin with, and then layer on top of it a crisis.
Oh, wow. Thank you, Donna. Okay.
I can go next. Certainly I would echo everything that Donna just said. I think from, it really has significantly impacted women and children. I think, from my perspective, in the Department of OBGYN at a hospital, there was already a lot of fear and anxiety around COVID and around what was the impact going to be on individuals' health. But then if you look specifically at our mothers and our women who were pregnant as COVID was happening, for the women who became pregnant during COVID and who then delivered, this just increased the fear and anxiety of what is going to happen to me as a pregnant woman, what is going to happen to my baby, what is going to happen to my young children. It just, increased that exponentially. And so I think that, the anxiety and stress on our moms it just has become really untenable for some people. And then, like Donna said, you layer on that already, many social determinants of health that were negatively impacted by disparities in outcome already, and then compounded by the effects and the impact of COVID. The one thing that I do specifically want to mention as well is the economic impact of women in the workplace also, because this significantly impacts women's health and social determinants of health. We know that the impact of COVID has really put women back decades in the advances that we made as far as achieving gender equity in the workplace, both as it relates to pay, as it relates to distribution of household duties, as it relates to economic development for women in leadership positions. We've lost decades of ground in that area. And that's not only do we need to heal and progress from COVID and the impacts on healthcare, but the specific economic impact on women it has been tremendous, and that will continue to impact women's health and outcomes and how they care for and support their children as well.
Thank you. Thank you, Dr. Zavitsky.
Thanks.
Okay.
So working in the birth, working in birth, we've noticed that a lot of times women were very fearful of birth to begin with. A lot of women need to understand what's happening to their bodies or feel like they're in control of their labor experience. And so we saw that a lot of women were feeling like they were not able, a lot of laboring individuals were not able to be in control of their labor experience. And so there was actually a study that was done in 2000 that said that specifically Black women felt like they needed to have the support of their partner, a female family member, usually a mother, and a doula or support person for them to feel secure during labor and delivery. And so as you can imagine, COVID drastically changed our ability to be in the labor and delivery room. And so there was oftentimes that we were preparing a woman for labor and delivery with the expectations of being there, but policies changing, which we understand sometimes kept us out of being in that room with them. And so we view ourselves as part of the care team. And so it was very difficult to make promises to individuals that we would be there for their family and for them to have the labor experience that they wanted when we just weren't sure what the policies would be from month to month. So that was a very difficult impact on labor and delivery.
Wow, thank you.
And then I think to kind of take it from there, we're mentioning for OB, for Dr. Zavitsky, how they're stressed during the time of the delivery. But that stress actually continues on as they continue to raise their children in an environment that's totally different than what it was before. Kids that are usually socialized at a very young age, they're not able to get out and do that. So they're wondering what's going to happen for their child and how this is going to affect them long term. And then when we look at school in general, once they get to the school, the disparities there for those who don't have access to a good virtual learning kind of environment, or for those who have to stay at home or go to different locations to get that Wi-Fi to be able to do this. And so it really just brought back a lot of disparities that are there and added a lot of stress to the families and mothers and made them have to kind of work a little harder or try to find new ways of trying to get that education in and to really help their children to keep them on track.
Wow. See, we only have 45 minutes, ladies, and you've opened up Pandora's box here. But really, you're talking about not just the physical, but the mental, economic impact of COVID-19 on mothers and children, but also the future success of their children. And that, for me, as a retired educator, is very important because we're seeing that backlash right now in the schools. What happened when you give children unsupervised, professional unsupervised. Mom, I'm a grandma, so I get it. I appreciate the work that I can do, but when you're working and trying to manage a home and trying to manage your educational success and trying to manage everything else, it's very difficult. So that I think that's a whole nother session to talk about the mental health, which is something we probably don't have the time to talk a lot about. But that mental health piece is, I think, critical as I continue to work with and talk with new moms. So Donna, I'd like to start with you, if you don't mind, and ask you just some statistics. I don't want a lot. Obviously, we're here because of the disparities that we see, but can you give us some up-to-date statistics about the number of people who have been affected, and then compare that in Summit County to the number of minorities who are being affected? And then I want to bring it back, obviously, to our mothers and our children. Donna, you're muted.
Yeah, after 21 months, you'd think I'd learn the mute button as well. So let me just start high level. and then we'll kind of dive in a little deeper. And I promise I have practiced, I will be succinct because I can talk a lot. So let me just talk about the overall, and then we'll kind of dive deep. If you put it in this sort of framing, about 5% of all of Summit County's population has had COVID-19. It's creeping up on about 6%. Of those, about 9% of the people were hospitalized who had COVID. And 20% of those folks ended up in the ICU. And 43% of everybody who went to an ICU ended up ventilated. And then about half of all ventilator patients, unfortunately, don't make it. They succumb to COVID-19 and the issues. And so when you look at it like that, you think, wow, we really have as a community suffered some great loss, and we have. It's been tremendous loss for all of us, not to mention, and I'm sure, folks have mentioned it, the hours of work, the hours of unsupervised time for children, just this absolute sort of vortex we were all dropped into. But what I want to make sure that we understand is, when you look at crude rates, meaning just counting people and looking, if you look at the white rate, it's about 261 per 100,000. And when you look at the Black rate, it's 265. And one might make the assumption quickly that there really weren't those great disparities, but that absolutely is not true. Those rates are not adjusted for any age or demographic. Those are simply crude rates. And they're simply not accurate when it talks about the devastation that we have seen among minority communities. So let's talk about what is the real white rate. It's about 89.7 per 100,000. But if you look at Black, it's almost double that. It's 155.3 per 100,000. So we have a significant more number of cases in a smaller population. And then if you look at Asian, it's 71.9. And the reason I point out those three groups are that they're the largest constituents of the population in Summit County. And then if you move on and you look at vaccination rates, our vaccination rates for whites are somewhere around almost 56% in total in Summit County, and Black African is only 36.6. And Asian is about 62.7. So when we think about these numbers and we look at the overall impact, minority communities who probably were more likely to work in jobs that didn't have paid sick time, worked on the front line in support positions in healthcare, were more likely to have employment in support positions in restaurants, were able to work in nursing facilities, nursing homes, and we know how hard they were hit in the beginning in long-term care, congregate living. So basically what you were just showing was that individuals who do not have equal opportunity were getting much sicker, much more often, and paying the greatest price because of the circumstances. And I think Dr. Zavitsky mentioned the social determinants. And it is those social determinants: living in substandard housing, not having adequate resources, good nutrition. And probably one of the largest reasons that accounted for the minority disparity was starting out in poor health to begin with. Because if you had more or one chronic condition, hypertension, renal disease, cardiovascular disease, that puts you at far greater risk than your counterparts in the population who may have only had one risk factor that was well controlled because they had access to healthcare, they had access to medication. So, I mean, we have to be very careful when we try to tell this story. It is not the crude numbers that matter. It is the impact on populations that matter. And that would be especially true for our youngest, most vulnerable. Because if you're a mom or a family and you struggle with getting access to healthcare and taking care of your own healthcare, you're most likely not going to be able to take care of your little one's healthcare either. It makes it hard for you to get where you need to get and what you need. Plus, we live in such a sophisticated world. I mean, if there's one thing, that COVID has taught me is that technologically, we left a whole generation of people behind and we shouldn't have. Because you had to know a lot to survive the pandemic and you had to be connected. And it was very difficult to set up systems where you weren't.
Sorry, I mute myself as well because often I'm writing or doing whatever. I'm glad you brought up that point because I know in the beginning, some of us in the African-American community were very frustrated because we kept hearing some of the data. And it's like, so what kind of strategies are we going to put in place to ensure that we are reaching those who are most vulnerable? And I know it was difficult at times, but at least we came up with a plan to help make sure that we could help increase those numbers. But I hope we've learned something from that process so that we don't have to go through that again, that we recognize that these social determinants of health are real and that we have to continue to work together better to ensure that people get what they need. So I noticed when you were talking about some of the data, it doesn't break it down by women, obviously. It just did by racial groups and ethnicity. Why keep that kind of data? Why is it important?
Yeah, and I have to tell you, if another lesson we learned, it's extremely important that we tell the story accurately. Yes. And I have to say, without reliable data, and data in this environment has been a struggle because we've had so many providers, we've had so many labs involved, we've had everybody involved. It's been very difficult to get reliable information. It's even been difficult to get race because we're not the only people who test to vaccinate. And if you don't take the time to mark race, then we don't get that information. Mm-hmm. And so we really have to concentrate on getting the good data in so that we can do the good outcome analysis on the back end. And I personally think that we have about 10% of every case we have is an unknown race. And some people have chosen not to tell their race, and that's okay. But a lot of it is just for the lack of collecting the data and not having it. If you do look at the numbers specific to females, it's about 47% males are affected and about 50-some% females. There's more women than men that have actually had COVID.
Interesting. I hope that we start to look at this data and start creating our own templates to help do a better job and working with them. So thank you for sharing that. I was also concerned about the number of children recently that we have seen in the news that either have been affected and are passing away from COVID-19. Do you have any of that data to share?
Yeah, within Summit County, our numbers have increased. Children's Hospital used to have about 20 admissions a week for COVID-19, and that has subsequently dropped down to about 15. All in total, we have about 18 cases so far of MIS, which is the multi-system inflammatory disease syndrome for children that are post-COVID. So we have had some significant illness in Summit County and around the country, obviously. So it isn't as though every child does not get that sick. Some don't, and we're very hopeful that with vaccine now and some other mitigation strategies that children will be more protected than ever, but it doesn't escape children.
Gotcha. I know, because when you share that data, that 5% of the Summit population had COVID at some time, some people will say, well, why are we all getting vaccinated for quote unquote 5%? But I think the exponential factor of how many people can be affected is what's really important. And that data doesn't share that. As someone who was asymptomatic, I don't know how many people I came in contact with. I
Right.
only found out because I was going to some of the centers and saying, hey, come over here. This one, the lines aren't too long. Come over to this site. And I would get swabbed. And then one time they said, hey, by the way, you have COVID. I'm like, no, I don't. But having had no symptoms, nothing, but I don't know who I impacted. And that fear of who I could have possibly impacted was a major reason I decided to get vaccinated. I don't want that on my conscience. So thank you for sharing. Dr. Sims, as a pediatrician, help us understand why children should get vaccinated. Is it safe? You know, I hear so many conversations about, oh my gosh, it's going to affect them with child rearing, or it could cause deformities. Help us understand.
Sure. And so early on in the pandemic, we were still kind of learning of the nuances of COVID-19. And we thought that it was a disease more for like the elderly, so to speak, or disease for the older population. We thought that children weren't likely to get COVID, or if they did, it was pretty mild or form of the disease. The main thing we were kind of focused on was, again, that MISC that was just mentioned, that inflammatory syndrome that kind of happened post-COVID. But then we found that the Delta variant is a little bit more serious, and it is affecting the children, the younger children. According to the CDC, the infection rates are about, for children 5 to 17, are just as high as it is for adults 18 to 49, and those even higher for those over the age of 50. So children are making up about 15% of all COVID vaccine, cases in the United States. And about 5 million have happened since about April of 2020. And so we're aware that, it can cause some acute complications as well as prolonged courses, but the vaccines can kind of help to curb some of those numbers. At Akron Children's, for the entirety of the pandemic, we have not had a single patient that was admitted for COVID or the MISC who had been fully vaccinated. So it just goes to show the effects of this vaccine. Along with the physical disease, COVID is also impacting the lives, like I mentioned earlier, of the kids in other ways, of the quarantines and the shutdowns, the virtual learning kind of thing. And so we're hoping that with this vaccine, we can kind of get back to school and get back to some sense of normalcy. It's finding that behavioral and mental health crises now with children is kind of the second pandemic of COVID. And so with that vaccine, we look to improve that. And then family is actually, also being affected with the children. And so that extended, family, like you mentioned, you want to stay away from people. You didn't know who you were affecting. And so with grandparents and cousins, aunts, you just really don't know. And so it'd be nice for this holiday season to be able to celebrate with family kind of, safely without being concerned. But of course, there's always going to come that question of the effectiveness of the vaccine and the safety of the vaccine. And so this vaccine has been shown to be safe. Over 429 million doses have been given out, and about 58% or 192 million people are fully vaccinated. And we haven't seen, major complications from it. I'll speak about Pfizer more specifically, just because that's the one that's actually allowed for the children less than, down to age of 5. But this vaccine is 94% effective at preventing symptomatic disease and 80% at preventing the infection itself, even with like minor cases. It's also been shown to be 93% effective at preventing hospitalizations in children 12 to 18 years of age. And now the new research is showing that it's 90% effective in children 5 to 11. So we are seeing that it is actually very, very, very safe and very effective. Again, we haven't really seen anyone in Akron Children's or even some of the other children's hospitals in Ohio that have had the vaccine that are being admitted.
Well, but the vaccine was just offered and available to children, so that kind of makes sense, right?
Correct.
So as a mother, as a grandmother mainly, how help the audience understand the vetting process for vaccines? Why would I encourage my grandchildren or their mother to get them vaccinated?
Sure. And we found that the vaccine or all vaccines is
Right.
probably among like the greatest biomedical and public health achievement of all times. It helps to prevent any sort of disease. And this is even going back into history of the time. And so when you look at it, the very first vaccines actually happened at about in like 1796. And that was with like the smallpox vaccine. And from there, we've actually just been able to save lives. And we figured that vaccines itself save about 2 to 3 million, prevent 2 to 3 million deaths per year. And so with that, we know that doing other ways of trying to prevent illnesses, we just have not seen anything work as well as vaccines.
Okay, so the key is, and I think this is important for all of us to understand, is it helps to prevent deaths. It doesn't say it will keep everybody from getting COVID-19. But the key word I heard from you is prevent deaths. Am I correct?
Correct. Preventing death and serious illness. Those who have been, like you mentioned, you had like an asymptomatic kind of case. We're seeing that those who are vaccinated, although they may still shed the virus and they may actually contract COVID, it's usually a lot less severe. They're usually more less contagious and not contagious for as long. And so that's being the key points of it, preventing that spread of infection, and it does prevent the serious effects of COVID.
Okay, so this, because COVID-19, obviously people think it just happened. The COVID-19, that means we've had 19 strands. Am I correct on that? 19 strands of this little wonderful bug that is driving us all crazy. But this Delta variant has obviously impacted our younger population in a greater sense. And so we haven't had this vaccine available for that long. What are some of the side effects that we've noted that parents need to know? And what can you tell us when we look at pros and cons, why we should do this?
Yes. And so when we say that the COVID-19, you are correct in that this is not a new strain. We've actually had, it's actually called SARS-CoV-2, meaning that there was another SARS that was previously around. And so we've been working on this vaccine for a little while. So it's not a brand new vaccine, which is what I think some people are thinking, that it just kind of came out of the blue. This is something that has been worked on for a while there. But as far as for some of those side effects that you're seeing, majority of the time you're seeing more of the local kind of reaction. You might get like a little bit of a fever or the chills, some muscle ache, some soreness. But that just shows you that your body is actually trying to mount that response to this, so that when it does see this infection actually full throttle, that it's able to kind of go out and mount the response that it needs to prevent anything from happening or prevent you from having a serious infection. And so we actually, although we don't like to feel that way, we know that it is working, and our body has recognized that is a pathogen that's not supposed to be there, and it's working to get rid of it.
Okay. And, of course, if you're a part of the Facebook world, it will share with you all of the crazy stories of, oh my God, this kid, lost his life. Oh my God, this, how do we help give good information? Do you guys have on your website, or where can we go to get really good, solid from the experts?
Sure. And we would say definitely Akron Children's is always trying to put out the most up-to-date information. So making sure to check with Akron Children's website on the web page actually has a COVID-19 page there. Looking at things from very reputable sources. Again, yes, staying away from the social medias, but looking at the CDC, the American Academy of Pediatrics. Those are reputable sources that actually are getting scientific information and more up-to-date information for you. So those would be ones I would choose, more from hospital sites and not personal blogs and things like that.
Okay, because I also believe that I think so often when we look at, and hindsight's always 2020, but when we look at the information that came out about COVID-19, it started talking about, oh, if you're older, so everybody else kind of forgot about it. Then it's like, oh, shoot, now if you're this, oh, and so people were like, okay, I'm not that either. Oh, if you're this. And so those folks who are fairly healthy, like myself, or I think I am, and who don't have a whole lot of pre-existing conditions, we think, oh, why should I get this vaccine, or why should my children worry about it? But it is a bigger picture is what I'm hearing. And we need to look at that as well. So I appreciate your thoughts on this and how we can think about it for our children. Thank you. Dr. Zavitsky. Um, this vaccine, and we have so many, how in the world could it be recommended for our expectant moms?
Yeah, it's your last point about how that information evolved and changed over time. Boy, pregnancy has been one of those areas where this has changed significantly. It's so funny. I was going through some emails from like January to March of 2020, and just the changes in perspective, the changes in perception of how this disease was impacting our pregnant moms has changed tremendously. And, I can tell you in the very beginning, as obstetricians and people who care for or provide services for pregnant moms, we were all kind of holding our breath because on the one hand, we knew that respiratory diseases like the flu has significant impacts on our pregnant moms. And I think our general society has recognized that if a pregnant woman gets the flu, her chance of becoming severely ill and her chance of dying is actually really high. And so, the concept of getting a flu vaccine in pregnancy is, we've made so much progress in getting our moms vaccinated against the flu. So when COVID came out, I will be honest, a lot of obstetricians, a lot of caregivers for pregnant women were very scared because we were worried that this was going to be just like the flu. However, in the very early stages, and I'm talking like March, April of 2020, we weren't necessarily seeing that yet because of a lot of what like Donna was talking about, how that data is interpreted, how the data is reported. We really didn't get good confirmatory data until later in the summer and early fall, when of course our biggest fears were realized and we found that the severity of illness in pregnant women was significant. And then if you look at a pregnant woman who gets COVID versus a non-pregnant woman who gets COVID, that pregnant woman is at a much higher, has a much higher chance of getting pneumonia, of having to be admitted to the ICU, of having to be on a ventilator. And in fact, some of the data that we've seen so far has shown that if a pregnant woman gets COVID, she has a 22 times higher chance of dying than if a non-pregnant woman gets COVID. So once we realize the severity of the disease and the severity of the impact that it could have on pregnant women, and as we saw this evolution of the development of the vaccine, I'll be very honest, it was very simple for us to put all of the information together and say, absolutely, pregnant women should be vaccinated. And I think from an anecdotal standpoint, a lot of physicians, a lot of scientists, a lot of caregivers for pregnant women had come to that conclusion because we already felt very comfortable with the concept of giving vaccines to pregnant women. We have a lot of data about vaccine safety in pregnancy. And like Dr. Sims said, this vaccine didn't just come out of thin air. These vaccines, this type of technology has been in development for many years. And so we had already a comfort level of vaccination in pregnancy. I can say now, though, because we have nearly 200,000 pregnant women across the country who have been vaccinated, and the data again and again and again shows that there is no increased risk of any abnormal or adverse pregnancy outcome with a vaccine. And this has been studied specifically in women who got the vaccine before they got pregnant and then became pregnant, got vaccine in early pregnancy, in mid-pregnancy, in late pregnancy, and the data is all the same across all of those populations. It is safe to take in pregnancy and in the preconception period. It's safe to take while you're breastfeeding. And in fact, we know that breastfeeding moms are passing on those incredible antibodies to their babies if they've been vaccinated against COVID-19. So the moms are actually giving their babies extra protection when they breastfeed. We also know that the COVID illness, not only does it increase the risk of mom having to be in the ICU and intubated and also dying, but it actually increases the risk of complications in pregnancy. We know that pregnant women who get COVID-19 are at a higher risk of developing preeclampsia. They're at a higher risk of delivering early or having a preterm birth. They're at a higher risk of stillbirth. And they're also at a higher risk of having a baby who is what we consider low birth weight. And then those babies are at a higher risk of developing what we call severe morbidity or mortality as well when they're being born by those moms, because they're being born at a lower weight and a lower gestational age or at a preterm time frame. So I can unequivocally say that all of the national organizations that have anything to do with pregnant moms or the prenatal period are absolutely recommending the vaccine. We know it's saving lives, it's saving mothers' lives, it's saving their babies' lives as well. And we have zero concern about adverse reactions or significant adverse associations of things happening with the vaccine in these pregnant women.
Okay, so I'm going to bring this back around to where we are right here in Akron, Ohio, and with the mommies that you see that come in there.
Yes.
First of all, African-American females, we all know about some of the, all the things that happened in the past. And I hear what you're saying about what you're saying, but I'm going to tell you, we bring all that to the table when we come into your office. How do you convince a mom? What do you say to that African-American mom to ensure her one, or to even convince her to take that vaccine?
Yeah, from my standpoint, and I think that a lot of people in kind of my area and with Dr. Sims as well, is we have to meet those patients where they are. Sometimes it's not about me convincing them to take it, as it is about me listening to their concerns and really having a conversation with them around, tell me what is the reason, what is the reason why you're hesitant to take it? And not just, I think sometimes in medicine, we just like, no, you should do this and you should do that, but that's really not, that's not meeting the patients where they're at. And that's what we need to do. We need to have conversation. We need to have dialogue. We need to really get an understanding of where they're coming from so that we can help to dispel any misinformation that they may have, but then also encourage people who have experienced previous trauma or who have experienced, whether it's, in their own lives or just generational, like you said, Black people have been used in scientific studies in very bad ways, have been excluded from treatment regimens intentionally, that there's no denying that. And so we have to have that conversation and dispel any of those myths that currently exist to help people feel more comfortable about making that decision. And then for those individuals who choose not to come up with a plan to help to protect them as well. Because we can't just write off people and say, okay, you're not going to get the vaccine. Well, then, good luck to you. We have to have a conversation to say, okay, you're choosing not to get the vaccine. Okay, these are the risks, and let's have a conversation about why you have that hesitancy. But now let's talk a little bit about what are the precautions that you need to take now to try to protect yourself from getting COVID as well.
Wow. Now that goes back to something I believe in wholeheartedly. It's about trusted partners, trusted individuals. Do they trust children? Do they trust the health department? Do they trust the doulas? Do they trust their primary care physician? Because I will tell you, in one family alone, one doctor says, oh, you don't need to get that vaccine. And I'm like, what? No, yes, you need to get that vaccine, and that's coming from mom or grandma, as opposed to, well, my doctor said, and I'm like, okay, I need to have a conversation with your doctor because I think there's a bigger picture than what they're seeing. But again, it's about listening. And as you said, that if you're not going to, then let's come up with a plan. And I think that's the first time I've heard a professional say that, which leads me right into India Robertson. I bet that's all of what you guys do, is really help moms come up with a plan as they begin to deliver their babies.
Exactly. So I like that you were talking about trust, because the women that we serve in the communities that we serve really do trust us. And so they see us as an extension of their own family. We are involved as early as 6 weeks in some cases in people's pregnancy. And so we are there a year postpartum. So it was very important that our administrative team sat down in a meeting and collectively decided that we will all be vaccinated. And so we did that because we know that people trust us first because we're in their homes, we are meeting with them. And so we decided that part of our plan was to make sure that we're still wearing our masks, even though we're vaccinated, that we're having these conversations. And because individuals trust us, we're leading by example in those cases. The next part of it is that we are still attending births, and that's really important. And so our team is there. And so even if a mother is COVID positive, we will still attend those births. We have people who are vaccinated who have identified that they are totally okay with still attending those births, and we have. So that has happened. It's not just a plan that's been in place. We're making sure that we protect the people that we serve. For myself, I'm a lactation consultant, certified lactation consultant. So I am making touches in the community. I need to be vaccinated to make sure that the people who are trusting me to serve them in that way are being protected from me. And also that I have the conversations about whether or not they are vaccinated in a safe way, where they feel like they can ask me questions about being vaccinated because they do trust us. And I've had people who will give me, information that I know is misinformation. And then they'll say, well, I've heard if you get it that this is going to happen. And then I'll say, what, did you know that I was vaccinated? And they'll say, oh my gosh. Oh, wow. I didn't know that. Okay. Now I feel comfortable even asking you more questions and having this conversation in a safe way that's non-judgmental, that I know that I can really get my concerns answered. And so we've had classes that discussed it. We are childbirth educators. So we want to make sure that we're able to discuss this in an open format. We've utilized evidence-based information for people as it has become available to make sure that they are really informed and not being overtaken with all the misinformation that social media sometimes can bombard people's lives with. We understand that a lot of people felt very isolated. Yeah. And so us still being in the home with them kind of helps them, come out of that isolation and feel like, okay, well, let's go on a walk at the park. Let's still make sure that we're social distancing. Let's still wear a mask, but we want to make sure that you are getting out of the home and that, and also if you have a new baby, not everybody has learned how to change a diaper. Not everybody has learned those key care things that they need to learn as a new mom. And so we can't just leave them to say, okay, you are going to have to figure this out on your own. It's very important that we quickly went virtual, but then we also educated ourselves on what information is real so that we can continue to assist people through the process of, navigating the pandemic. And in the end, we found that now we have people who will call and they'll say, well, I really want to do it. I really believe in what you do. I really love the support, but I want to make sure that individual is vaccinated. And that's because they themselves they really understand that vaccination is important. And so we wanted to make sure that we could provide people with individuals who are vaccinated so that they could have the experience and labor that they want, that we've already figured out is the right experience and the right support for people. But we needed to do it so that they can say, okay, is the person that I'm inviting into my life and into my home vaccinated also?
Wow. So you meet with them before, during, and after the birth.
Yes. Yes.
And you maintain and build real trust in a way that others, we don't have that opportunity. Exactly. And so I think that's very, very powerful. So all of the doulas that you work with are trained? Are vaccinated?
So all of our full-time staff is vaccinated, and almost all of our doula team, I would say we are about 70% right now. And so we do continue to trust that the people who are not vaccinated, just by being around other individuals, we do believe in having conversations so that they can feel safe in asking questions and make the right decision for themselves. But our full-time team is completely vaccinated.
Great, great. So what about the African-American moms that you serve? It sounds like you're saying they really do understand the importance of the vaccine.
Yes, yes. And even the ones who are not vaccinated themselves, they are very comfortable asking us questions. And so we consider ourselves, and I would say that many of our partner health systems have considered us to be an extension of the medical care team. And so with that being said, we are able to go to births that maybe people who are not part of our organization are not able to go to. And so we want to make sure that we continue to be able to do that, but at the same time, have those conversations and really build trust within each individual's family so that they can ask us the questions that they need to ask. We've had people who would ask me about breastfeeding, but they would never ask anybody else in their family that.
Right.
Or people who would ask me, I'm a grandmother. I have a 1.5-year-old grandson. And it was important for me to become vaccinated because I wanted to be able to protect my grandson. And so in doing that, his mother, father, everyone else in the family just followed suit. So it feels very nice for me to be able to tell the people who we serve that, my entire family, my entire household is vaccinated so that they can see that some of the misinformation that they've heard is not true. I'm not experiencing any of these far-fetched claims that other people, and also teach individuals how to vet information and what information is real. And, if your cousin's cousin said it, but you don't know that person, let's say that is probably not credible. And so it's no different than people having fears of breastfeeding and coming and asking questions about that because they heard their cousin say something about that. So this is how we actually handle all information. It's just through education in a safe space.
And it sounds like you guys do a lot of listening as well and tailor what you do to meet the needs. I agree with you. I don't think people understand. I call it like a wraparound kind of services. I know we talked about it in education. So we have the health department working with the providers, working with you so that we can all give the same message and also do what needs to be done to keep families and mothers safe. I think that's critical. And I don't think a lot of people understand that goes on because we just assume you are working with me or my physician is working with me or my gynecologist, but they're not thinking that all of us are working together. And I think that's important for us to do a better job in the medical profession, I think in society in general, that we're all in this together. Because I think when this pandemic started, it didn't feel that way, but we've learned a lot. And I'm really thankful for each and every one of you on this panel because you've brought to light some really important information. I'm not good at keeping time, but I'm trying to watch the time. But I do have one question that I want each of you to answer for me because I think it's important as a mother, as a grandmother, that I'd like to know from your personal perspective. In 1 or 2 sentences, as a woman, as a mother, as a professional, what has this pandemic taught you, 1? And then 2, what would you say to individuals who still don't believe in the vaccine? I know that's tough. Give you a chance to think about it. Normally, when I moderate a panel, I throw out my questions and I have a conversation with all of you beforehand. And I did not do that this time. I apologize. But I want you to think about that because it's important to me. Okay, Tamika says she's watching the time. Okay, all right. Because I really think it's important for people to hear your heart because we heard your professionalism. You guys are awesome. But I would like to give you a chance to think about that. I think Andrea and Donna, I mentioned that to you before when we got started. So Andrea, Dr. Sims, would you mind starting first and we'll come back to the others?
Sure. I think the biggest thing that I've learned is that we're very resilient, and children are very resilient. And so we've been hit with a lot of information. Things are constantly changing, and we together are coming to figure this out. And as we're learning, we're changing and adapting to the situation. They were able to start a virtual school kind of, rapidly to get things going and get people moving. And so I think as we continue to work together and continue to kind of really push for the answer, which whether it may be making sure we're masks and making sure we're protecting everyone, getting the vaccine, vaccine. I think that's going to be our biggest push, is how do we all work together to get this accomplished. And so far we have several bodies that are all kind of pushing for this vaccine, saying that it is safe, having the numbers. So I guess my biggest also information to everyone would be that we've seen the numbers, we know it's safe, and that's going to be the fastest way to kind of get us back to that sense of normalcy, will be that vaccine and really working together. And so those would be my quick two little sentences there. But yes, just really that resiliency, and we're showing that we're able to get through this.
Oh, awesome. Thank you. I keep forgetting I was muted. India, are you ready, or you want me to come back to you?
No, I'm ready.
Okay.
I think that what it has taught us as an organization is that communication is key. So we very quickly had to become remote and figure out how to take all of our services virtual and quickly made sure that we were communicating with one another from our homes. And one thing that we did learn through communication is that we still work remotely, all of us do. And that has taught us all how to really work together and making sure that all the wheels are still turning from all the different homes. And that flexibility was important. For anybody who is still has concerns, I would say that you should find someone who is vaccinated and have a conversation with them, a safe conversation. And so if you have heard anything, or if you know anything, or think you know anything, that is one of the reasons that I think that people are they just maybe don't know that someone else is vaccinated. And I feel like some people who are vaccinated are just afraid to tell people that they know, because they don't want to be judged for, it's such an interesting dynamic. But ask people if they are and have a conversation with them. Not a judgmental, not an argument, not a debate. Just, hey, what was the experience like for you? What have you, what has happened since that? And that will help us all to become more comfortable with the idea.
Great. Thank you. Donna.
Thank you. I think the one thing that has resonated with me is that, first of all, we will never, we have an opportunity right now to rebuild in the right way. And we need to do that. We know we left people behind. We know that people were left behind before this. We know now that we have the opportunity to make policy changes and infrastructure changes to help everyone be successful. And we would be fools if we let this opportunity go and we didn't take advantage of it.
Wow. Sorry, I'm a scripter. Well, and then Donna, what else could you say to someone? I know, poor thing, you're everywhere trying to help people understand how important it is to take the vaccine. What's that final thought you want to try to?
I think, yeah, it's been hard. And I know I come from a place where, we've talked to the 60-some thousand people that have been ill.
Right.
We have seen the death. I have seen 66-year-old people die and their 84-year-old mothers walk out of the hospital. I have seen youngsters get really ill. I have seen youngsters folks who now have COVID long, and the long COVID that has left them with a cardiac arrhythmia or some sort of a kidney problem. So the COVID disease itself is so much worse than what any vaccine could ever do to you. And I think that just from where I sit, and I know I have a very eyeball look at it, but we have heard the tragedy, and I just wish everybody would realize it's preventable tragedy. We just have to pull together.
Wow, thank you. And Dr. Zavitsky.
Thank you for letting me go last, because a little bit of time to think about this. I think I really want to echo what Dr. Sims said about resilience. I do actually presentations on resilience. I do training on resilience, and boy, I tell you what, my resilience was tested these last, nearly 2 years. And honestly, it's put resilience in a perspective that I've never had before. And I think part of that is kind of to what Donna is talking about, where, it's not just about me. It's not just about my family. It's about the whole community. And it's really, really put that into perspective for me that, that I have a duty to my community. And I think that COVID has really reinforced that, and honestly has really reinvigorated me as far as that responsibility to the community and my whole department as well. And so, for those individuals who are hesitant, who have hesitancy around the vaccine, I would just really encourage them to talk about it with someone and trust, and for those individuals who have gotten the vaccine and who are feeling very rigid about the vaccine, let your mind be open to have a conversation with someone who has vaccine hesitancy. We can't make this just all or none. We have to somehow find each other in the middle and have these conversations and build these relationships of trust so that we will want to care for our community and to make these decisions for the betterment of our community.
Wow. First of all, I want to say that I feel honored to have been asked to facilitate this panel. You're amazing women doing amazing work. And I hope you stay focused on what it is that God has called you to do, because it resonated with me, and I'm sure it resonated with the others in the audience. But what I heard you say is that we are resilient. Communication is key. And if we don't rebuild in the right way and make the changes to help everyone be successful, then shame on us, because this is a unique opportunity. I just want to say power to the women, one, and then two, thank you for bringing a powerful message that we all needed to hear. I'm going to stop now because I'll get preachy. So it was my honor and privilege to be in your presence and to listen to each of you talk about your passion and your heart and the work that you do. Thank you.
Thank you.
Thank you, Judy, and thank you to all of the panelists. It was a great conversation. If I couldn't have done a better job if I had scripted it myself, because you guys did a great job. It's like everything that that you think, but you guys did a fabulous job and I appreciate it. And Miss Judy Hill, fabulous facilitator of this conversation. Thank you so much. You were awesome. I received text messages that you were doing a fantastic job, and they're so happy that I selected you to facilitate this conversation. So kudos to you, and kudos to the doctors, the doulas, and Donna. We've been together for the 21 months, texting each other and everything. So thank you guys for all of the hard work you do for the community, and I appreciate your time today. Thank you. We're now going to turn it over and talk about the state of infant mortality in our community. And I'm going to turn it over to Shalita Smith, who is a rock star, one of the young adults in this community that is going to receive the Athena Award later this week. So Shalita is the manager for maternal and child health at Summit County Public Health, and she's going to give us a presentation on the state of infant mortality here in Summit County. Thank you.
Thank you, Tamika. Can you see my screen? I'm sorry, I got Horrigan. I don't know what's happening.
Yes, we're good.
Okay, perfect. Good afternoon, everyone, and thank you for giving me this opportunity to give you a little bit of an overview around infant mortality. Today, I want to talk a little bit about what infant mortality is. I'm going to identify the problem from a state perspective, but also from a local perspective. And also, I'm going to talk about how we're addressing it locally. I know you heard Miss Judy Hill state a little bit about what full-term first birthday is, but I'm going to give you a little bit of a deeper dive of the things that we're doing and how we're addressing our community. Hold on. Okay, so infant mortality is defined as the death before a child's first birthday. And one of the things that we like to say about infant mortality rate as a whole, it is one of the most sensitive indicators of societal health, as well as a marker of maternal and child health. So infant mortality rates as a whole really defines how our community is doing as a whole. So when we talk about our disparities in our community, when we're having conversations about how our women are doing and how our children are thriving, that really is a reflection of how our community is doing as a whole. So all these conversations that we're having about disparity is extremely important because it just tells us all the things that we need to focus on as we move forward. So currently in Ohio, we are still using 2019 numbers. The way that the numbers kind of work are we're a little bit behind, obviously because of COVID, but also the way that filing runs, you have about 3 to 4 months after the end of the year to do some filing, but due to COVID, there was a lot of late filing this year. So 2020 numbers have not been finalized, but our infant mortality rate was 6.9 per 1,000 live births, which is about 20% higher than the national average. And then if you look at the white infant mortality rate versus the Black infant mortality rate, you can see the numbers. It's a huge disparity, right? So as you can see, about 3 infants are dying each day, and our Black babies are dying at almost 3 times the rate of our white babies. So this disparity alone is something that obviously we need to pay attention to. And if you look back in history, which I know we're going to talk about very soon, this is a reoccurring thing. The disparity has been persisting for years, and we have a lot of work to do, but we are trending in the right direction. So next I want to talk about a little bit of how we even get this information and what we do from a state and local level. So there's something called the Child Fatality Review Board. This board is mandated by the Ohio Revised Code, and it is charged with reviewing every single child death in the state of Ohio, okay? So in Summit County, the way that our board works, we have 26 members on our board. Our board is made up of various local agencies, hospital systems, some grassroots agencies, a lot of social service agencies, and our medical examiner. And what we review is we review every single child death in Summit County. We review approximately 45 to 50 child deaths a year, but majority of those deaths are infant deaths, meaning the child is under the age of 1. On that board, we look at medical information. We bring information to the table in terms of if there was some type of investigation, if it was an accident, and we have any type of police sighting or EMS sighting at the time of the incident. All that information is brought to the table, and we have a conversation. We have a conversation about what we could have done in the community as social service providers and as responders to the community at large to make sure that this does not happen in the future or to prevent this child or future children's death. At the end of the day, we make a decision whether it was preventable or non-preventable. And we're coming from a lens of, was this something within the systems that we could have prevented or medically we could have prevented? So that's how we make that decision, whether it's preventable or non-preventable death. And then we make recommendations. We recommendations about how we can provide further education, how we can talk about how this can be decreased in the future, how we can be more aware. So it's a very fruitful conversation. I will say in 2020, it got a little strange. It used to be 26 of us gathered in a room having fruitful conversation, looking across at each other every other month. But starting in COVID, we had to respond and we went virtual. And within that conversation, I think that it's really encouraged everyone to appreciate the fact that we have a really important job, and the work that we do is really impactful in terms of how we make recommendations and how we move forward in our community. So infant mortality, there's a couple different types of things that we talk about in terms of losses. Sudden infant death syndrome, asphyxiation, which is typically due to a sleep-related incident, accidental death, which could be anything from a drowning, a motor vehicle accident, anything of that nature, birth defects, or complications due to prematurity are the main causes of our infants dying in Summit County. The reason that complications due to prematurity is highlighted red and bolded is because approximately 35 to 40% of our infant deaths every year are due to prematurity. And when we talk about prematurity, it's a hard thing to understand and conceptualize because you can't touch it. You can't feel it. You can't understand it. There's so many things that go into it. But there's lots of things that we review when it comes to infant mortality. When it comes to prematurity, we talk about obesity, we talk about the health of mom, we talk about social determinants of health, which is the environment of which someone lives in. And we talk about stress a lot. I know the panelists that just spoke talked about the stress and the conditions of COVID and how it impacted everyone very heavily from, do I have a job today? Do I have housing? Do I have transportation? And that's something that we take into consideration. And one of the things that we really don't get to talk about are fetal deaths. And we do have a review board, a group of individuals that are mostly healthcare providers and social service providers as well, that talks about fetal deaths. And within the fetal death, we talk about any child, any baby that dies 20 weeks gestation, up to obviously in womb, up to 39, 40, but the child is not actually a live birth. And what we do with that information is we try to do interviews. And within those interviews, we're trying to gather the things that we're not getting from medical records. So we're trying to find out, did you have a house over your head? Were you having any relationship issues? Were you stressed? Is there anything that we could have did to help prevent this loss? And then what we do with that information, once again, is we provide recommendations into the community. Fetal deaths are not taken into consideration into the infant mortality rates, but they are something that's near and dear because there's a lot of research that you can gather from that information to try to change the systems moving forward. So in 2013, the Ohio Department of Health formed the Ohio Equity Institute. The Ohio Equity Institute is made up of 9 counties, and the counties that are in pink, you can see, are the 9 counties, Summit County being one of them. And the purpose of the OEI counties was to develop an effort to address key drivers of inequities in infant mortality and prioritize these populations due to the birth outcomes being so poor. In 2019, 2/3 of the mothers who experienced an infant loss lived in these 9 counties alone. I'm going to say that again. 2/3, that's 66% of the mothers that experienced the infant loss in the state of Ohio lived in these 9 counties alone. So that's huge. And a disproportionate number of those losses were to Black women. So with that being said, these 9 counties came together in 2013 and we continue to persist. We're working together to combine efforts to figure out how we can combat infant mortality as a unit, but also create ways to strategize to do it individually. Because our counties, they are kind of similar, but they are very different. And as we all know, our community is very unique in their ways and what they respond to. So we have to make sure that what we're doing is reflective of the community as a whole, but also we're being responsive to the state. And making sure that everything is in line in terms of our goals and objectives. So unfortunately, in 2022, we will be expanding to 10 counties, adding Lorain County into the equation. Their infant mortality rates has risen a lot over the last couple years. It's been a topic of conversation for about 2 or 3 years now, and they will be added into the OEI group as of January of 2022. So let's talk about our community. Summit County has almost 6,000 births a year. And of those 6,000 births, approximately 40% of them are to residents of Akron. As a whole, we have been seeing a gradual decrease in the birth rate in Summit County. And this is pretty consistent with national data as well. According to the Center for Disease Control, the U.S. birth rate fell by 4% in 2020 alone. So although we don't fully know the reason of the birth rate declining, there's a lot of things that researchers and scientists and medical professionals are taking into consideration. And a lot of those revolve around societal and economical factors and the cost of living. Things are just different in how, Donna and some of our panelists were just talking about the things that you have to consider when raising a family. So something to consider, and hopefully within the next couple of years, we'll be having some more babies. So we're going to talk about the disparity. In 2019, Summit County experienced 35 infant deaths, making the infant mortality rate 5.81 deaths per 1,000 live births. The white infant mortality rate was 2.07 deaths per 1,000 live births, and our Black infant mortality rate was 15.61 deaths per 1,000 live births. So our Black babies are dying at a much, much higher rate than our white babies. Approximately 60% of the deaths were neonatal deaths. That means that our babies didn't even make it to 1 month old. So we have worked with some of our hospital systems to try to do some research on what's happening, to see if these babies are entering the NICU, if there's some educational factors that we can look into. And that's something that we will continue to do because we feel like that is extremely high in our community, and it's something that we need to really focus on and zoom in on because our babies aren't even making it to one month old. Since 2013, Summit County has been experiencing an average of 40 infant deaths per year. So in order to get that number, we really just took the numbers, the deaths that we've had, and we did an average over the years. But the biggest thing that we saw in 2019 is this is the highest disparity that we've had between white and Black deaths that we've seen since we really started looking at our infant mortality rate in death, which is in 2007. So one of the things that we like to do within our work is really zoom in on the community as a whole, and look at geographically our zip codes and how our zip codes and geographical populations and how they're playing into things. So these two graphs that I have here, one is our infant mortality rates by zip in race in code in 2018, and then the other one is 2019. And I am not a huge fan of showing a year glimpse at all, but when I was looking at the data, this really, really popped out at me. The fact that in 2019 there were no white infant deaths in these 5 zip codes was very, very shocking. And these 5 zip codes are considered our hotspot zip codes, of which we like to call them. And we call them that because those are our areas in our community which have the highest infant mortality rates. They also have a higher, a decent percentage of individuals who are of minority descent. So not just AfricanAmerican or Black people living in these communities, but a variety of cultures and various races. So it's something that we're definitely looking into. Unfortunately, due to COVID, we didn't get to do as much of a dive into this information as we would have liked because we didn't get this information till a little bit like mid 2020. And because we were in the middle of the pandemic, we didn't get to do as much literature and research as we wanted. So now we're backtracking to try to figure out if there was anything in particular that changed during this year process that caused this major episode to happen in these communities. To our knowledge, there's nothing that changed that was as drastic, but we're trying to figure out if there was an educational platform, if there was a resource that was there that then went away. And if so, that's something that we need to look into and bring back. So one of the things that is very heavily talked about in our work is sleep-related deaths. And I just want to say that when we talk about sleep-related infant deaths, this does include sudden infant deaths. So this is just not co-sleeping. So in 2019, we saw a huge rise in our sleep-related deaths to 14. And of those 14 deaths, 9 of them was to co-sleeping. So when we talk about co-sleeping, we're talking about anything from in the bed with another individual. That could be mom, dad, uncle, brother, sister, or an animal. We also that includes the couch. Any place that is not in a crib, pack and play, bassinet, by yourself, nothing around you, just the baby. So that was a huge concern for us. So we definitely increased our education and did a lot of networking and development with our local children's hospital to figure out what's going on. As far as our preliminary numbers for 2020, we did see a decrease. We did not hit that 14 number, which is fantastic, but the number was higher preliminary than it has been in the previous years. So as you can see, in 2016, we only had 5, but our goal was to get to 0. I know some of our OEI communities have really gotten to 0. So we're just trying to figure out how can we do a better job of educating the community? What are we missing? We're obviously missing the mark on something. The winter months are a really, really trying time. We understand that it's cold. We understand that some of the housing conditions in our community are not great. And we're trying to do a better job of being available and providing that education. And also there's resources so that we do not have any more of these sleep-related deaths. So where are we now? Full-term first birthday was mentioned previously, but I just want to give a little bit of additional overview. So we started this in 2017. Tamika and myself co-chair this initiative, and it's such amazing work. It's one of those things where I was hesitant at first, I will say so, but really we've come together and everybody who is at the table truly is there to impact the community. And you can just feel the love and the energy every time you step into a meeting. So at the bottom of this slide, I put infant vitality versus infant mortality. And the reason I did that is because about 3 years ago, we made it a point that we need to stop talking about the deaths of our baby in the community and talking about how we're changing the story and how we're changing the narrative to talk about the longevity of our kids in our community. We have to do more to prepare families for childbearing age and for prenatal care and postpartum. And then we also have to do a good job of taking care of our families and our children after they have their child. As we know, there's a lot of work that has to be done between the ages of 0 and 5. And that's why we're avidly working with communities and organizations in Summit County that really work on child kindergarten readiness. We're bridging the gap. Our goal is to make sure that we have everything across the continuum from preconception, which is before you even get pregnant, before you even think about it, make sure your health is good, all the way up to your child is ready to go to school and beyond. So this has been a great initiative and I'm so excited to be a part of it. And as we talk about our priorities, one of the biggest things that we just talk about is increasing access, educational resources for pregnant people and families. We're just really here to be a resource. We're here to advocate. We're here to make sure that it's available. And if it's not available, one of the first things I ask, okay, how can we get it? Identifying those gaps and reducing the barriers related to social determinants of health. And then advocating for policy and practice change. One of the biggest things that we've been seeing is that a lot of the policies were made a lot of years ago, and they really don't work with how things run today. They don't work with technology, and more importantly, they don't work with how COVID has changed the world. So really taking the time to look into those policies, look into those different systems and say, okay, well, maybe we can't fully change it, but how can we adapt it to make sure that we're keeping the client's interest at heart and making sure that we're doing what's best for the community as a whole. So when we talk about our efforts directly, I'm just going to give you a couple overviews of some things that we've done. We've worked very heavily with United Way and our partners to identify a screening and referring process. This process has been huge and very instrumental in all the avenues of getting clients into our direct-based services. 211 has developed a resource online. I think it's called Healthy Babies something. It's a widget. My apologies. I don't know the exact name, but it has all the local resources available for pregnant women, families, and postpartum women and fathers in the community. It's a really great resource. Also, they've hired people specifically to help work with us, and then they refer out to our partner. So if they're doing a screening and they find that an individual is saying, oh, I don't have a pack to play, or I don't have a safe place for my baby to sleep, they know who they need to contact and who they need to get in touch with to make sure that that is mitigated. It's a great relationship, and it really has changed how we kind of move in the future. As far as housing insecurity, we have a program here at Summit County Public Health where we screen pregnant women. And during these efforts, we found that 60% of the women that we screened indicated that they had some type of housing insecurity. And that could be from as far-fetched as them sleeping in their car or not having a roof over their head at all, or they could just be couch surfing or sleeping at an aunt's house. But they did not feel like they had a place specifically to call home. And with that being said, we made it a very large priority to develop a couple different practices, and we have some great things up and coming around getting a sustainable and quality housing to our pregnant women. So that is something that we are working on very diligently. Workforce development training goes hand in hand with housing. We found, although we were giving housing support, we had a really, really hard time getting our individuals or our clients to maintain housing because they did not have stable income. So we have worked with the Well CDC to give some dollars for some training to do workforce development. And they have a program of which is phenomenal. They work with various agencies and some hospital systems and other corporations in the community to do a full slate of training, from personal professional development to financial planning, to how to do your resume, to interviewing skills, everything. Excuse me. So the great thing about the program is if you go through the program, the full, if it's a 4-week training, 5-week training, whatever it is, you are guaranteed a job interview. It's really great work. And not to mention, you also receive different incentives along the way. There's childcare provided, there's a meal. It's really something that we're very proud of, and we've actually received some national funding and some state funding to operate this training. And then the biggest thing that we learned, especially in the last 365, is that we have to invite the community to the table. So we've been very diligent with hiring some consultants to assist us with this. We've been working on safe sleep. We've done a few different surveys along with some focus groups. Within these surveys and focus groups, what we've been finding is that our community knows the information, but they're not following it, but we still don't know why. So to be determined on that. But we are realizing that there's a lack of trust. So maybe it's how we display the information. Maybe there needs to be more of a personal touch to the story. And we need to get someone to advocate, to tell their story about losing their child, which is a very sensitive topic, obviously. But something is missing. So we have a lot of work to do on that, but we're very excited that we are getting the authentic engagement from the community, and they're willing and able to talk to us from a real point of view. We learned that we have to tell our story. Not only do we have to tell our story from a collaborative, but we also have to tell our story from the client perspective. So what we're doing is we're working with a marketing company to develop a platform website where we will be telling stories of our clients, how our services have benefited them, how the resources have changed their lives, how they've been able to navigate different situations and have had successful births and success in their professional career moving forward. And then also, we allow the community to participate in our next steps. And what that means is we've decided that we can no longer come to the table and make decisions for the community. So we have young women who are participating in our focus groups, in our strategic planning sessions, in our subcommittees. And within that, we're getting great information, and we are paying them. We understand that their time is valuable, just as ours. And it takes time to come to the table and be a part of those conversations. So all this work is done by everybody involved. We have over 40 partners that come together. We're very fortunate that it's very organic, and we're all there to support for the same cause. And I'm just really happy that we've come to understand that our babies are our future, and in order to make a true change, we have to work together. and address the community from a holistic view and listen to their needs. So that's all I have. Tamika, you're on mute.
Oh my gosh. I said all of that. I will restate, and Jake didn't even tell me that I was on mute. I want to say thank you, Shalita, for that great presentation and the data that you shared with the community, and the talking about what we're doing for full-term first birthday and how we're trying to help our moms. Well, we are helping our moms. We are helping our moms. And I think it's very key that we are the collaborative, we're doing so much great work. And I think the key piece in that data is why the mayor allowed for us to declare racism as a public health crisis, is because we are doing everything. The hospitals are doing a great job in informing mothers of what to do. As we went through the focus groups, the moms know the ABCs of safe sleep. They're just not practicing them. So what is it that we're missing? And Shalita and I we have a technical assistance grant, and we heard Dr. Arthur James speak about racism and the impact it has on infant mortality. And so Dr. James is here today. Dr. James is an obstetrician, gynecologist, and pediatrician who has been involved in the care of underserved populations for the entirety of his medical career. He has been the medical director of 2 different neighborhood health centers, the medical director of Bronson Methodist Hospital's Women's Care Clinic, and founding medical director of Borges Medical Center's Women's Health Office. So, Dr. James, I will turn it over to you. I truly appreciate you coming to talk about this and providing the clear and very candid conversation that racism is a public health crisis, and racism is part of the reason that our babies are dying, that our Black babies are dying. And so I'm going to turn the floor over to you. And thank you again.
Thank you very much. Can you hear me okay?
Yes, we can hear you.
Okay. I appreciate the opportunity to be involved in your summit. I think this is very important information. Before I dive into my talk, one thing I do want to clarify in terms of Lorain County finally joining the Ohio Institute for Equity and Birth Outcomes. As a consultant to the Ohio Department of Health, I was the architect behind the development of the Ohio Equity Institute, and personally went around and met all 9 health commissioners for the communities that are involved to convince them to be a part of this. I also met with the health commissioner of Lorain County at that time and was not able to convince her to be a part. So I'm actually happy to hear that Lorain County will soon become a part of the Institute, because their numbers are consistent with the other 9 counties that are engaged in this effort. So as you can see, the title of my talk, Equity and the Opportunity to Survive the First Year of Life for Black Babies in particular, that has been a dream deferred. I have nothing significant to disclose. I have some pretty aggressive objectives for this talk. Most of my data will concentrate on the state of Ohio, although I do have some information regarding Summit County and Akron that I will also share. I have no conflicts of interest. I do want everybody, though, to understand some of the bias that I bring to this conversation. After practicing for as long as I have, I've come to the conclusion that, of course, the racial disparity in birth outcomes is the most problematic maternal child health challenge facing this nation. That, as I hope all of us understand at this point, that race is a social construct, it's not a biological construct. And so our differences based on race do not account for the differences that we see in terms of maternal and infant morbidity and mortality. In my opinion, racism, both historical and contemporary, is the root cause for the disparities. And if the eradication of racism was up to Black people or people of color, it would have been eradicated a long time ago. Government agencies at all levels, white people and white organizations have to want to dismantle racism and co-lead the charge to do so. And in my opinion, this is essential to saving our mothers and babies. I also want you to understand that this is not an infant mortality lecture. It is unapologetically a talk about the Black-white racial disparity and the opportunity to survive the first year of life. So let me start by trying to answer the question why we should even have an interest in inequities and why investigate infant mortality. I'll go back to 1985, although we could go back a lot further, but I'll start with the what is commonly referred to as the Heckler Report, where while Secretary of Health and Human Services, Margaret Heckler led the effort to study the racial disparities in health outcomes in general in our country, and decided that people of color have not benefited equitably from the progress in our health system. Furthermore, particularly for African Americans, but minority groups in general, she found that there were 60,000 excess deaths that occur in our country every year, and that 80% of those deaths occurred in 6 healthcare areas, one of which, of course, was infant mortality. In 2002, the Institute of Medicine produced this landmark study called Unequal Treatment, where they in fact confirmed the findings of the Heckler Report done 17 years previously. One of the members of that committee that did that study said that considerable evidence suggests that these striking racial differences in health and their persistence over time reflect in large part policies and practices that are linked to the historic legacy of racism. And that legacy has created living conditions that are pathogenic for minority populations. And then in 2005, former Surgeon General David Satcher and the group that he put together analyzed the deaths that occurred in 2002 and found that there were 83,000 excess deaths that year to African Americans compared to whites. Now, a more recent study just released 2 months ago, less than 2 months ago actually, looked at those excess deaths again. So if each of these dots represents 10 people who died, if we map those deaths out by age for white people in the United States, this is the way the graph would look. Now, if we superimpose on that the deaths to Black people, then this is the way that superimposition would look. About 20% of those deaths are excess deaths, meaning that Black people died at significantly younger ages than their white counterparts did, and much earlier than we would normally expect. Significant for our conversation is that for any age that was looked at for excess deaths, the most excess deaths Black compared to white occurred during the first year of life. And of course, that's infant mortality. Now, this next slide I wasn't going to show for our talk, but after your conversation with the panel this morning, I thought I would throw it in because I think it's important. So those data I just showed you were for deaths in 2019. If we look at the impact of COVID on the Black community in particular, then total mortality by population among Black men was 26% higher than white men in 2019, but it was 45% higher in 2020. And similarly, in 2019, the total mortality by population among Black women was 15% higher than amongst white women. But in 2020, again, as a consequence of COVID, it was 32% higher. Infant mortality has already been defined for you. This does not include fetal deaths. It does not include miscarriages. And internationally is recognized as the most sensitive indicator we have for social well-being. It's also a community mirror, so it tells us something about where we live in our collective capacity to protect the youngest and most vulnerable. The Secretary's Advisory Committee on Infant Mortality in 2013 reminded us that the contributors to infant mortality were multifactorial, that it's not just about high quality healthcare, but I hope you'll recognize 2 through 5 here as being representative of social determinants. But then there is this paragraph at the end that I think is important for us to appreciate and understand, that our ability to prevent infant deaths and to address longstanding disparities is a barometer or a measure, if you will, of our society's commitment to the health and well-being of all women, children, and families. This was also reviewed with you earlier, that while infant mortality is the death of any live-born baby prior to his or her first birthday, most deaths occur during the neonatal period of time. About 2/3 of infant deaths occur then, and the most common causes are prematurity and congenital anomalies. And from 28 days to a year of age, we refer to that as post-neonatal deaths. And of course, sleep-related deaths are the most common contributors. But that is background. There are 4 characteristics of Ohio's data that I want to review. And if we have time, look a bit at Regional 5 infant mortality data. So where Ohio data is concerned, we're going to look at a data set that covers 49 years from 1970 to 2019. And as you can see on this slide, the overall infant mortality rate for our state improved by 63%. When we look at that by Black-white infant mortality rate, so this is the Black infant mortality rate, the red line is the white infant mortality rate. We're going to get rid of the overall line of the blue line so we can accent the persistence in this disparity. And I'll remind you of that statement made by the Secretary's Advisory Group, that the persistence in such a gap is a measure of our commitment to the health and well-being of all women, babies, and families. This looks briefly at Summit County's data. So for overall white and Black infant mortality from 2007 to 2020. And once again, we'll get rid of the overall line to accentuate the disparity as we go through our slides. But I just want you to see here that there is, again, this significant gap that exists in terms of opportunity to survive the first year of life. Now we're going to take a look at the Black-white inequity or disparity ratio. This 49-year set of data, if we start in 1970, Black babies died at about 1.8 times the rate of white babies. Even though the Black infant mortality rate and the white infant mortality rate improved during this period of time, when we arrive at 2019, the disparity ratio has increased to 2.64 times the rate of white babies. And that 2.64, by the way, is an improvement because during most of this time, the disparity ratio had Black babies dying at 3 times the rate of white babies. The disparity ratio, of course, increases because the white infant mortality rate improves at a faster pace than the Black infant mortality rate. I'm going to say that again because for points we're going to make later in the talk, it's important that you appreciate this. The disparity rate increases because the white infant mortality rate improves at a faster pace than the Black infant mortality rate. Nationally, Black babies die at 2 times the rate of white babies. In the state of Ohio, generally speaking, 3 times the rate of white babies. So this looks again at Summit County data for 2020. The disparity ratio is 2.2. Now, as you heard earlier, if we looked at this for Akron for 2019, Black babies in the city of Akron died at 7.5 times the rate of white babies. I think that's important information for you to remember. So this data from 2007 to 2020, what I've done is to put in trend lines because I want it to be clear to you that there's an increasing gap in the opportunity to survive the first year of life for Black babies compared to white babies. Now, this is happening on your watch while you're responsible for this, that the gap in the opportunity to survive the first year of life has been going up. And to make it clear, this graph looks at just the disparity ratio, the inequity ratio during that same period of time. Now, if the opportunity to survive the first year of life was the same for Black babies and white babies, that red dotted line would be a straight line, straight horizontal line. It wouldn't have a significant increasing angle as it does in this graph. And it once again is confirmatory information for what these trend lines here are telling us, that in fact, the gap is widening. Our goal, of course, is to eliminate that gap. At least our goal should be to eliminate that gap. So I digress to this Running Man slide to make the point. If in fact we were interested in the runner who is behind catching up to the runner who is in front, and we were not going to allow the runner in front to slow down so the runner who is behind can catch up, then I think all of you will appreciate that the only way for that to occur is for the runner who is behind to run faster than the runner who is in front. The same is the case then where infant mortality is concerned. If we're going to eliminate the gap, then we have to improve the Black infant mortality rate at a faster pace than we improve the white infant mortality rate. And just like in this example, we have to do that without compromising the rate of improvement in the white infant mortality rate. If I go back to this slide, what this slide is telling us is that the runner who is behind in this graph is falling further behind. It's just the opposite of what we want to achieve. Now, I've given versions of this talk all over the state and in 38 of the 48 continental United States. And regularly, some of the feedback I get is that it would be wrong, immoral, unjust, unfair for us to ever work on improving the opportunity to survive the first year of life for one group more than we do for another group. But I remind you of our own data. We've been doing this for decades, and everybody behaves as if it's okay. We behave as if this is normal, and it is not. And that's part of what we have to have the courage to change in this state. Now, another characteristic of the same data set is this thing I've made up. You won't find it in the literature, at least not yet. It's called a crude survival time lag. And I'm doing it because when people look at the disparity or inequity ratio, we've gone accustomed to saying, oh, Black babies die 2 times the rate of white babies or 3 times the rate of white babies. And then we move on. As I've said earlier, we behave as if that's normal and if it's okay. I think this concept of the survival time lag helps you to appreciate the significance of that gap. So here's what I mean by this. If in the state of Ohio, our Black infant mortality rate is in 2019 was 14 deaths for 1,000 live births, then the challenge is to go back in time to find a comparable white infant mortality rate. We have to go back 44 years to 1975. Now remember, we're talking about a 49-year data set here. So a data set that gives us reliable trends. This data set says then that if we don't change what we're doing and we have to wait another 44 years for Black babies to catch up to where white babies were in 29, that the state of Ohio is telling people who look like me that our babies have to wait until the year 2063 to experience the same opportunity of surviving the first year of life as white babies did in 2019. Now, we think that's unfair. We think it's unjust. We know that it's wrong. Another characteristic of this same data set that I want us to look at is how Ohio has done relative to achieving healthy people goals As you all recall, back in 1990 or before 1990, our goal by the time we got to 1990 for infant mortality is that we wanted an overall infant mortality rate of 9, a Black infant mortality rate of 12 by the time we got to 1990. In the state of Ohio, we achieved that overall infant mortality rate for white babies in 1987, well in advance of the goal date. For Healthy People 2000, we said that by the time we got to the year 2000, we wanted an overall infant mortality rate of 7, a Black infant mortality rate of 11. In the state of Ohio, we achieved that overall infant mortality rate for white babies in 1996, again, well in advance of the goal date. For Healthy People 2010, under Dr. Satcher's guidance, we said we wanted to do away with this disparate aspiration for surviving the first year of life by race. And we set in a very aggressive goal that by the time we got to 2010, we wanted all groups to experience an infant mortality rate no greater than 4.5 deaths per 1,000 live births. We did not achieve that goal for white babies or Black babies in the state of Ohio. We've just completed Healthy People 2020, and we said that by the time we got to 2020, we wanted all groups to experience an infant mortality rate no greater than 6 deaths per 1,000 live births. In the state of Ohio, we achieved that goal for white babies in 2014, again, well in advance of the goal date. The state of Ohio, in 4 decades of Healthy People, has never achieved any Healthy People goal for Black babies. I'm going to repeat that. The state of Ohio has never, ever achieved any Healthy People goal for Black babies. So that where achieving Healthy People goals is concerned, I think that Ohio has established racially determined patterns. That for 3 of the 4 decades, we've achieved the goals for white babies and did so in advance of the goal dates. And after 4 decades, never achieving any goal for Black babies. So these numbers at the bottom of the slide are just to remind me to ask you questions. So if I ask you to tell me the number after 2, 4, 6, 8, I think all of you would tell me the next number is 10. Or 5, 10, 15, 20, all of you would tell me the next number is 25. And you can, with absolute assurance, tell me what that next number is based on the pattern, the trend established by the numbers preceding it. So it is with infant mortality. You look at the disparities that have existed, our inability to achieve Healthy People goals for Black babies while we've done so for white babies. And if we don't change those patterns, and it's just as reliably as you can predict the next numbers here, you can tell us that Black babies are nowhere close to experiencing an equitable opportunity to survive the first year of life as white babies. So now we're operating under the auspices of Healthy People 2030, which says that by the time we get to 2030, we want all groups to experience an infant mortality rate no greater than 5. If we look at Ohio 2018 numbers, this is where we stand by race. So that you can see that in 2018, white babies were almost already at the rate, the 2030 goal of 5. Black babies have a long way to go. Hispanic babies should get there. And of course, Asian Pacific Islanders have already achieved the goal. So here we are, using 2018 as a baseline with a Black infant mortality rate of 13.9, then it means that in the next 12 years from 2018, we have to improve the Black infant mortality rate by 64%, while only improving the white infant mortality rate by 7.4% to get to the Healthy People 2030 goal. So I'm going to ask you, has the state of Ohio put a plan on the table that's going to allow us to achieve the Black infant mortality rate by 64% in the next several years? I think not. And I'm bringing that up, making it very clear to you, because if in fact we're serious about eliminating this disparity, then your local community not only has to hold yourselves accountable for achieving that goal of 5, but you also need to hold the state accountable for doing the same. And then there's this area of excess Black infant deaths. If we look at the 3-year aggregate period of time, 2016, 17, and 18, then in the state of Ohio, 582 Black babies would still be alive if the Black infant mortality rate was the same as the white infant mortality rate. To put it in context, if the average classroom size is 25 students, then in the state of Ohio, we lose 8 classrooms of Black babies every year because of this excess infant death issue. This is not a fluke for us. If we look at the state of Ohio, well, this graph looks at all states that haven't had enough Black births and Black infant deaths to be considered statistically reliable in the entire United States. And in 2017, Ohio was next to the worst Black infant mortality rate in the nation. The same was the case for 2018. As a matter of fact, this was the 4th year in a row that we were next to the worst in the country for Black babies dying. And if you compare the Black infant mortality rate in 2018 in Ohio to, for example, what it was in Colorado, Black babies in the state of Ohio died at 2 times the rate of Black babies in Colorado. Now, I point that out because a lot of times we still operate under this false conception that, there's something chromosomally or genetically inferior about Black people that causes our babies to be at increased risk for dying this early. So unless you can convince me that Black people who live in the state of Ohio are significantly genetically different than Black people who live in the state of Colorado, that argument doesn't fly. And in 2019, 5th year in a row that we're next to the worst place in the country for Black babies to be born. And you see the same kind of distribution. Now, if we look at this by cities, looking at a different 3-year aggregate period of time from 2017 to 2019, and we look at the cities in the country that have the highest Black infant mortality rates, I'm throwing this in because, of course, here's where we find Akron. But the worst city in the country for Black babies to be born is Cleveland. Akron is number 5 on that list. If we look by cities for the Black-white difference in infant mortality, so you take the Black infant mortality rate, subtract from it the white infant mortality rate, and here's the difference that you get. There is no city in our country with a bigger difference than Cleveland. Akron, unfortunately, is too high on that list. This is important information for us because what this data set is telling us is that some sort of way, the city of Akron is finding a way to save its white babies, but simultaneously, at the same time, finding a way to lose significant numbers of Black babies. This data set looks at cities in the state, in the country for excess Black infant deaths. And although Akron is not on this slide, what I want you to appreciate and understand is that Ohio dominates this list. We're the only state in the nation with 3 cities that are amongst the worst for excess Black infant deaths in this country. So all of that data leads to the question that I think is a real legitimate question. Do Black babies matter? Let's make it more specific. The Black babies in the state of Ohio matter. The Black babies in Summit County and the city of Akron matter. Now we can soften it a little bit and say, well, the Black babies matter as much as white babies. And while everybody always says yes, our actions don't support that response. So let's go into a little bit about why these disparities exist. First off, let's dispel this myth that there's something genetically wrong with Black people that accounts for the disparities that we see. We have 20 years now of the Genome Project that unequivocally has said to us that we are 99.9% genetically the same. 99.9% genetically the same. So that to the extent that our genes operate to create our physiology, our genetic differences, our physiologic differences on the basis of race do not account for why we have the racial disparities that exist, not just in birth outcomes, but across the board in this country. But we live in a nation that's fixated on that 0.1% genetic difference to explain away everything in terms of disparities. So despite the data, there are many who believe that the Black infant mortality rate can never improve. Many believe that the Black infant mortality rate is as high and as bad as it is because of genetics or group level flaws amongst those of us who are Black, and some of those erroneous characteristics that some people use to help explain the disparity are in the periphery of this slide. And there's essentially nobody that believes that the Black infant mortality rate can ever be the same as the white infant mortality rate. So as part of this section, I want to talk a little bit about the influence of stress, which was alluded to earlier. So this slide is not for me to run through the physiologic process of stress, but to help you understand the following. When we see a pregnant woman today, we say to her unequivocally that if she is experiencing a significant amount of stress, that stress can compromise the outcome of her pregnancy, that somehow that stress gets under her skin, gets incorporated into her physiology, and can, as I said, compromise the outcome of the pregnancy for her, but also that those physiologic changes associated with stress can be incorporated in her fetus and can compromise the outcome of the pregnancy for her fetus. Also significantly, we believe that the fetus who survives a significantly stressful pregnancy can pass on those concerning physiologic changes to subsequent generations. So I want you to think about that within the context of this history, that those of us of African ancestry arrived on the shores of this country, at least in large numbers, in 1619 and endured 246 years of slavery, followed by another 99 years of Jim Crow. Together, that's 345 years of toxic stress. It's only been 57 years since passage of the Civil Rights Act, and I think most of us of African ancestry would suggest to you that the playing field has never been level, including since passage of that act. But here's the bottom line. Slavery and Jim Crow together to this day account for 86% of the African American experience. 86% of the time when we, provided significant advantage to those of us who were white while simultaneously exposing those of us who were Black to significant disadvantage. And we never talk about that history whenever we compare Blacks compared to white today in any domain. We behave as if we're ahistorical when it comes to remembering this, but it's a significant contributor to why the disparities exist in unemployment, in housing, in food security, in any domain you care to mention. Now, we live under this United States Declaration of Independence that says that we hold these truths to be self-evident, that all men and now women are created equal, that they are endowed by their Creator with certain unalienable rights, that amongst these are life, liberty, and the pursuit of happiness. But we have lots of things that are constant reminders to us that not all of us benefit from that declaration equitably. Here we see a picture of Hurricane Katrina. But I remind you of the increased incidence of killing of unarmed Black people and people of color. This wave that's crossing the country right now for voter suppression, much of it aimed at communities of color. And of course, the persistence in this disparity in the opportunity to survive the first year of life. So a sobering reality for those of us who are African American in this country is that even though the North won the Civil War, we behave as if the South has won the peace. And at the end of the Civil War, understand that the United States was the largest slaveholding company in our country in the entire world. You fast forward another 100 years, And because of mass incarceration, we've arrested enough of the descendants of those slaves that now the United States has the highest incarceration rate of any nation on earth. So that the bottom line for those of us of African ancestry as citizens of this country is that we are dependent on the same government that enslaved and oppressed us to now slave us. And after 400 plus years, I think this government has proven to us that we don't rank high on their priority list. So this concept gets to be difficult for some people to accept. And sometimes some people want to tell me that I'm just presenting some people's distorted concept of critical race theory. So I want to digress again. And I want to ask you to play a game of Monopoly with me. But we're going to follow the regular rules with one significant change. We're going to divide into 3 different groups, Group A, B, and C. Group A will begin the game and play for 7 rounds. When it's time for round 8, Group B joins the same game and plays for another 7 rounds. And when it's time for round 15, Group C joins the game. I think all of us understand that the outcome for that game has been predetermined, that the outcome significantly favors the group that started the game early because they were able to go around the board and buy up property and pile up resources. And for those who followed them, if you land on their property, of course, you have to pay them. So it subjects those who started the game later to significant disadvantage. The advantage of those people who started the game early, therefore, accumulates over time, and simultaneously, the disadvantage to the later starters also accumulates over time. Now, it's interesting because as we apply this to society in general, what we find is that those people who were able to start the game earlier start believing that they are smarter, more deserving than the people who started the game later. And likewise, the people who have been disadvantaged begin that, well, maybe they're not as deserving, and that those people who started the game early, maybe they are superior or more deserving than the later starters. The point I'm trying to make here is that the outcome of the game has been determined by the rules, by the policies, practices, and systems that we set up. Now, this is just a game. So we can change the rules, but in life, we can also change the rules. We happen to live in a country that's worked real hard to keep certain people out, to limit opportunities for success for certain folks. And I've listed some examples here. I think all of you have seen various versions of these cartoons that look at the whole thing between inequality and equality. I like this one because it also includes equity and justice. So in the inequality box, I'm going to suggest that those 246 years of slavery and 99 years of Jim Crow, so 345 years, that we regularly practiced inequality in our country. And that, as I indicated in the Monopoly game and in the conversation before that, that over this period of time, advantage accumulated for some of us, disadvantage for others of us. In 1964, 57 years ago, we passed the Civil Rights Act, and we've tried to behave as if there was equality. And in this square, we've provided the same amount of assistance and help to both groups. And as you can tell in this picture, there's no equality here. The folks who were advantaged for those 345 years are still significantly advantaged. Where equity is concerned, we talk about providing more assistance and help to those people who have been disadvantaged for so long. But that by itself is not enough because we have structurally built our country in a way that advantages certain people. And so we have to figure out in terms of justice, how to balance that so that we can in fact achieve equity in outcomes. Here's the point. The disparities that exist in this country in infant mortality are not natural. We made it this way. And the only good thing about appreciating that is that if we made it that way, then it means that it's within our capability of changing it. So what are we going to do? Where are we going to go with this? I've created these bubbles, what I call the clinical social dyads, where the blue bubble here represents essentially the medical model. And the way we've approached things in the past for addressing medical issues is that we poured the overwhelming majority of our resources into the clinical area of concern and paid very little attention to the social issues. What modern studies have indicated to us is that the social stuff is at least as important as the clinical stuff. I think we make our best decisions in the area of overlap. And in fact, I think the majority of our resources need to be placed in the social, non-clinical area. That doesn't mean that I'm demeaning anything that we do clinically. As a clinician, I think that's very important. But the World Health Organization and others have told us that where we live, work, and play is where our health is determined most, so that the social issues are what we have to pay attention to. Yet when we talk about infant mortality, we talk about it almost purely in clinical terms. So as indicated earlier by myself and the talk previous to mine, that babies die from premature birth, congenital anomalies, et cetera. But when we are discussing disparities, then the social determinants get to be important. And so I've created this slide to help us understand that in order to achieve equity, we got to get to a point that we address all the stuff below the waterline in this slide. And if, in fact, our efforts remain strictly clinical, then we will never figure out what wrecked this boat in the first place. So this is a depiction of the social determinants: healthcare access, neighborhood and built environment, social community context, economic stability, et cetera. And we've understood that those are the important things that we need to impact. I want to help you understand another important concept here, and that is that policies, practices, and systems determined what the living conditions are going to be for each of us. And those living conditions have consequences. Let me make it clear. To the left are the causes of what's in the middle, the conditions that we live in. And those conditions that we live in have consequences. And when we create policies that favor some and disfavor others, we create a circumstance that has disparate consequences. And that's what we're seeing in our country. I'm driving this home in a different way because it's an important point that I think we all need to get. So these various bubbles look at different levels of the clinical factors that we usually invest in. And what I'm suggesting to you, that there are structural issues that we have to address that are never going to allow us to achieve equity if we don't address them. Important to this principle is something that Dr. Kamara Jones has taught us, is that to achieve equity, we have to get to a point that we value all individuals and populations equally, that we recognize and rectify historical justices, and that we provide resources according to need. Now, the health literature today tells us that achieving health equity is our goal. Nancy Krieger reminds us that social inequality kills, that it deprives individuals and communities of a healthy start in life, increases their burden of disability and disease, and brings early death, that poverty and discrimination, inadequate medical care, and the violation of human rights all act as powerful social determinants of who lives, who dies, at what age, and with what degree of suffering. And so in my opinion, it's going to be tough for us to achieve health equity if we don't make achieving overall equity our North Star. Achieve equity and everything else is derivative. Now, this is a picture that Isabel Wilkerson highlights in her new book, Caste, where It's a picture of railroad workers in 1936 that are all saluting the Fuhrer during that period of time. And of course, we know the devastation that Adolf Hitler caused to Jews during this period of time. The picture highlights this one man who, unlike the others, is not saluting, who, unlike the others, is not supportive of the current policies, practices, and system, who, unlike the others, sees the harm that's being caused by what's going on. And so the challenge to you all is this, that if the persistence in this disparity in our state at a time when we are responsible for the numbers is not enough for us to change, then what's it going to take? Obama suggested to us that change is not going to come if we wait for some other person or some other time, that we're the ones we've been waiting for, that we have to be the change that we seek. So all across this state, we have to help everybody understand that any baby who takes his or her first breath within the borders of Ohio is our responsibility, and we can and must do better. Now, back in 1989, when James Baldwin was asked about this whole issue of racism and it resolving, he said, and I embellish his quote with what I've added in red here, that you've always told me it takes more time. It's taken my father's time, my mother's time, my uncles and my aunt's time, my sister and my brother's time, my nieces and my nephews' time. And before them, it took my grandparents, great-grandparents, and great-great-grandparents' time. And now it denies any time to too many mothers and babies. So how much more time do you want for racial progress? At some point, some of us have to declare that now is that time. But the way the rules have been set up, think about the Monopoly game. Think about the slide I showed you with the social determinants in the middle. The way the rules have been set up, some of us experience more of an opportunity to succeed than others. This does not happen because some people are better than others, because some people have more flaws than others. We have set up this system, and it is not natural. For those of us who are in maternal child health, this is our responsibility to stand in those gaps and mitigate those crazy circumstances that place some of us at risk more than others. Nelson Mandela's life taught us that it always seems impossible until it's done. Thank you all very much. Now, I should add here that I have another talk that I'm giving for the state of Illinois' infant mortality group in a few minutes. So unfortunately, I'm not going to be able to take a lot of questions. I've told Tamika that if people want copies of these slides, that it's fine to provide you with the PDF version of the slides, PDF only because I don't want people changing the context of what I said. But what you're hearing is my perspective of what accounts for the racial disparities that we see in birth outcomes that is based, as I said in the initial slides, on about 33 years of experience of looking at this issue of concern. So I appreciate the opportunity to spend some time with you this afternoon. Thank you very much.
Thank you, Dr. James. We truly appreciate your knowledge and your candid presentation. And good luck at your next speaking engagement. Truly appreciate you making time for the city of Akron and Summit County.
Yeah.
At this time, we're going to take about a little bit under 15 minutes break, and we will be back at 3:30 to hear Jessica Ehill from the University of Nebraska. So we'll take about a break until 3:30. Thank you. Hello and welcome back. I know that was a very deep conversation that Dr. James had, and I knew that we were going to need a break. But we are now joined by Jessica Ehul, who currently serves as the Director of Programs for City Match, a national maternal and child health organization housed at the University of Nebraska Medical Center in Omaha, Nebraska. City Match partners with local city and county representatives to address disparities in maternal and child health outcomes, and builds the capacity of public health professionals and supports local level work toward creating equitable policies, programs, and procedures. In Jessica's current role, she leads the program team in the design and implementation of initiatives to eliminate birth disparities. Jessica, thank you for joining us today, and we look forward to hearing your presentation on how science, history, and policy shape maternal health outcomes.
Thank you so much, Tamika. I am just going to share my screen and make sure you all can see that clearly. Perfect. Thank you all for having me today. As Tamika mentioned, my name is Jessica Ehul. I am the Director of Programs at City Match. And I'm excited to just share a little bit with you all. And honestly, it will probably complement all that you've heard today. A lot of what Dr. James kind of touched on, I'm just going to get a little bit deeper into some specific historical policies that have shaped the MCH outcomes that we see. So some of it at the beginning won't be very new. I'm using some similar graphics and such, but I hope that you all will learn just a little bit more about some historical policies that have helped shape where we are today. So first, I would just like to mention, make sure my slides will advance, that I am presenting from Omaha, Nebraska. So the University of Nebraska Medical Center, where City Match is housed, is in Omaha, Nebraska, and I'm on the land of the Omaha tribe. And I have a couple of links there so you can find out a little bit more about the Omaha tribes. And also, if you don't know what native land you are on, I highly recommend that you find out. There's a link at the end of that slide there, not only to find out whose land you're on, but also about the history of that land. A lot of what I'll talk about today is based on history and knowing where we came from to understand and really develop strategies to get us where we need to go. So as we're talking about infant mortality and maternal mortality and all of these adverse birth outcomes, we really need to understand the why. And so my presentation today will really hinge on the why. I'm going to start with a little bit of foundational pieces around public health that you all are probably familiar with, but I just want to set us all in the same foundation. And then I'll move a little bit into science, just a smidge. Dr. James also talked a little bit about the science piece of it. And then I'll move more deeply into some historical policies and then kind of map how that has been translated to today. So we will go ahead and get started. This is familiar. You've seen this in presentations today. This is the social determinants of health. This is the graphic. And I just wanted to point out from here that this is where we're starting from when we need to understand the conditions in which people live, work, and play. Those are our social determinants. We're talking about education, access, and quality, economic stability, social and community context, neighborhood and built environment, and then also healthcare access and quality. I'll be speaking a lot to healthcare access and quality and the neighborhood and built environment, but also we'll touch on some of these other pieces as well. But this is just to say, health is not one thing, health is all of these things, and what the outcomes that we see will combine all of these things. One term, if you have not heard of this or if you're not familiar, is intersectionality. This was a term originally coined in 1989 by Professor Kimberly Crenshaw, and it really just talks about how aspects of a person's identity combine to create access to opportunities or discrimination throughout their lifetime. So the buckets that we have here are just examples. This is a graphic I'm using from an artist around racial identity, gender, sexuality, disability, and nationality. But this is not all inclusive of the identities that a person can have. But this is just to say we don't experience life in buckets. So you're not just your racial identity, and then over here your sexuality, and then over here your nationality. You are all of those things. Each and every person is a combination of all of those things, and we cannot experience life as in that different way. All of our identities combine and cannot be separated from one another. So this is just to say we experience life in many, many different ways. In addition to that, Dr. James touched on this. I want to bring in the life course perspective. The life course perspective just states that we live life in a complex interplay of biological, behavioral, psychological, and social factors. And throughout our lives, we'll experience protective and risk factors that contribute to the health outcomes that we see. So if you're looking at an individual, their life is not just their own. Their life has been impacted by their parents, so their mother and father. So when you're thinking about preconception, we're really looking at the mother and father of that individual. What was their life like? And then we're looking at the individual, but not just that individual, but actually also the next generation. So when we think about life course, we're looking over the lifespans and into other generations. And we know that health is not just in that one generation. It actually can have an impact throughout the generations to come. All right, so this next part I'm going to get into is just a touch on science before we get into some specific policies that have helped shape our outcomes. So Dr. James also touched on this a little bit. Dr. Arlene Geronimus, she is a professor at the University of Michigan, and she's been doing studies for probably about 20 years, research 20 years, maybe more than that now. Yes, more than that now, I think over 3 decades. And thinking about the weathering effect. So in her research, she really introduced this, noting that Black people in the United States are experiencing an excess morbidity and mortality, and really trying to understand why that was happening. She hypothesized that Black people are experiencing early health deterioration as a consequence of cumulative marginalization in social, economic, and political aspects. So I always use this example. We all experience stress. Stress is a very normal part of being human. Unfortunately, some people can experience stress for longer periods of time or at a higher load, and that will have a physiological impact. So if you are trying to run away from a bear, or if you're in danger, your body needs to turn that stress response on so that you can get out of that danger. What should happen, though, is that stress response should turn back down. And when that stress response does not turn down, we then hit levels of toxic stress and allostatic overload. So for many Black people living in the United States, they're experiencing constant levels of stress, and stress is continuing to come, and that stress level is never going down. Therefore, there's some deterioration of telomeres. So we all have chromosomes. On the ends of our chromosomes are telomeres on the ends of the DNA. And so Black women who have perceived racism in the United States, studies have shown that there is a deterioration on their telomeres. So I want to back up real quick. Telomere deterioration is natural in humans as you age. But when there's this premature deterioration, that can then have an impact on overall health, including reproductive health, as people are planning to get pregnant and expand their families. On this next slide, I just talk a little bit more about toxic stress and what that toxic stress can be due to. So it's that perception of racism, right? But it's also like the stresses that come from finances and employment, family dynamics, your lived environment. So where you live, work, play, all of those things can come in to accumulate the levels of stress. And then, as I stated previously, when a Black or brown person desires to become pregnant, they are often doing so at a point where their cells, mainly the telomeres on their chromosomes, have aged prematurely, and it can impact the outcome of baby, but it also impacts a number of various health outcomes, including life expectancy. And I'll talk about that in just a little bit. So this next part I'm about to go into is really diving into history and looking at some policies that we have and how that has impacted folks over time. So we're going to talk about 3 key areas. I just chose these as examples to show that kind of thread between the outcomes that we're seeing, and then how and why those outcomes are happening. So Dr. James gave us a lot of the data, and I'm not going to stick to the data. I'm going to do more of the why piece of it. Looking at these policies, how do they then connect to that maternal health outcome? So we're going to focus on 3 areas. This is not all inclusive. These are not all of the things that have impacted maternal and child health, but these are just 3 that have really interesting backgrounds that I think everyone should know about. So first, I'll dive into redlining. And I'm sure many of us have heard about redlining by now, but it is a discriminatory and unethical practice in which mortgage lenders and insurance companies deny services to residents of certain communities with specific populations for of people of color, but especially Black communities. So in the 1930s and 40s, there was a practice of marking land as worthy or unworthy. And so it was lines, like red lines, yellow, blue, and green, I believe, were the colors that were primarily used in cities across the nation. And this helped to determine the worthiness of that home, but then also helped to determine for the mortgage lenders and insurance companies who had access to investments and in buying homes and development. And so who were they going to give loans to even? But that practice of redlining has reverberated through everything that we see now. And so I'm going to show you a few maps and you'll see exactly what I mean. But when people were not having access to homes or loans to buy homes or establish their wealth through the process of home buying, that really impacted their employment, their education, health overall. When we think back to the toxic stress we just talked about and finances being one of those key things, that was definitely something that impacted families long term. And so I want to show you, sorry, it's not working that way. Okay. In some studies that we've seen recently, there's been a report that released that there are specific aspects of housing, such as housing quality, lack of safe and affordable housing. So being able to have housing that you feel is structurally sound, but also in a safe neighborhood that you can afford. Housing tenure, so the length of time that you've had a home, and then housing instability and homelessness have been associated with health inequities. In addition to that, a recent study just in 2020 found that there's a significant association between housing insecurity and the adverse birth outcomes that we see. So research has shown that there is a connection here, but I want to show you maps so you can see it for yourself. So I have a redlining map of Akron. You all have probably seen this before. As a reminder, so the land was kind of marked with like most desirable to least desirable. The most desirable or first grade in this case on this map is the green area you see. And then it goes to the blue, yellow, and red being the least desirable or 4th grade land. And I want you to just pay close attention to like this pattern here that you see. Where are you seeing the yellow and red? And then where are you seeing the blue and green? So on this next map here, I have the same redlining map next to a Summit County infant mortality rate map based on your 2007 to 2016 infant mortality data. So if we look at these two and compare, if you wanted to overlay these, where are you seeing the highest rates of infant mortality in comparison to where some of the red or yellow areas are on this redlining map? And where are you seeing some more of like the greenish or better health outcomes in comparison to where they are on this redlining map? So when we're talking about redlining, it's not just access to housing that's itself in a bucket. And that's what I meant by like, we are experiencing the social determinants of health, they all combine and they're all important for our overall health. So if you look at just the access to housing, basically what this redlining map is telling us versus our infant mortality rates. And we know that housing is a big issue in Akron. This didn't start today. This started many, many years ago, decades ago, through the foundation of this piece of legislation that allowed for redlining. And I'm going to show another example with Cleveland, your neighbors there. And I know there's probably some folks on the call from Cleveland as well. So you all have really great maps through, I believe it's the community group, I have them on the next one. They have great maps, so you all may have seen this before. This is the redlining map of Cuyahoga County. Same color scheme here, where blue and green are the more desirable pieces of land. Red is and the yellow are the least desirable pieces of land. And to be clear, the red and yellow land is often where they were giving land to people of color, Black people in particular. So just look at where that is. These are two maps that I pulled from the Center for Community Solutions. This shows you the poverty rate by census tract. And this also shows you the percent of population who is Black in Cuyahoga County. I'm gonna go back real quick just so you can get this redlining map pattern in your mind. And you see where the red and the yellow is, you see where the blue and the green is. Do you see a similar pattern here? We're looking at the darker areas of red are showing the higher rates of poverty on the left-hand side, and then the darker areas red on the right-hand side are showing the higher concentration of Black people. And it's not coincidental that we're seeing such a high poverty rate in some of the same areas that were red and yellow lined, and then some of the highest concentrations of Black people in those same areas. All right, I pulled the redlining map back up, but also wanted to compare this to life expectancy at birth. So when we're looking at life expectancy, the darker areas are the earlier deaths, and then the lighter areas are those that were able to live till later in life. And if you compare that to a redlining map, you see the same pattern. So I wanted to bring this all up to say, this is just one key factor in our history around redlining that has an impact on infant mortality rates, that has an impact on life expectancy, that has an impact on education and access to quality education, has an impact on poverty. And this is seen back from the 1930s and 40s. We still are seeing this today in 2021. So nearly 100 years later, none of these things are changing. That same kind of like template that was put in place has affected everything even unto this day. And so I wanted to bring up redlining just so if you don't know a whole lot about redlining, I highly recommend looking more into it. There's a wonderful book by Richard Rothstein called The Color of Law, and it tells you a bit more about redlining and how that has had an impact on communities across the nation. Akron and Cuyahoga County aren't the only ones. If you want to look it up across the state of Ohio, there are wonderful redlining maps available. Like you all have kept really good track of that in the state. But I think that sometimes folks don't understand how this initial practice of redlining has led to infant mortality rates being high and lack of access to safe and affordable housing and lack of access to quality education. All of this is interconnected because we do not experience life in buckets. The two other things that I want to bring up for you all really quickly are some policy specific things. So there was a report released in 1910 called the Flexner Report, and it was intended to establish like a gold standard of medical training. At that time, we did not have in the United States or in Canada like a standardized way of providing care and of making sure that people were educated. So in 1910, we established the Flexner Report. Was that needed? Absolutely. It was needed to make sure that there was a standard process of educating folks and people when they're seeking care, what they can expect to receive when it comes to healthcare access. However, as a consequence of this, at the time, there were only 7 medical schools for Black students. 5 of those 7 medical schools leaving Meharry Medical College and Howard University for the education of Black physicians, nurses, things of that nature. I want you to remember this is 1910. Black people could not be educated at all schools. So having those schools available for Black people was important, not only for making sure that Black doctors, nurses, and other healthcare professionals were afforded the opportunity of education, but also to make sure that the community had people to care for them. Because oftentimes, Black and brown folks could not go to a whites only hospital. So if they had a medical emergency and they needed to go to a hospital, they were often turned away at the door. So if a mom was giving birth to a baby, they couldn't always go to a hospital. Honestly, a lot of the times they were using the help of like midwives, granny midwives, and such in their community to provide those obstetric services. But I just want to mention how this particular policy then changed where we are today. So what you see here is a graph from the AAMC. And this is a graph that's just talking a little bit about the physicians' rate by ethnicity. I just want to point out the large percentage, 56.2% of all physicians, practicing physicians, active physicians in 2018 were white. If you look at kind of like this lighter blue color, only 5% were African-American. This that we're seeing today in 2018 is a consequence of the Flexner report. So I want you all to understand how our history and our policies that are put in place have an impact for generations to come, right, on how we're able to access care, who's available, and all of those things. So this is important. I really wanted to mention this piece, but I also want to talk a little bit about obstetric care. So the Flexner report standardized medical care, but it made it so that not everyone had access to medical education, and therefore then diminished the amount of Black physicians that were available. Not only that, shortly thereafter, in 1921, the Promotion of Welfare and the Hygiene of Maternity and Infancy Act was in place. It's also known as the Shepard-Towner Act. This was necessary too, because in 1921, we were experiencing as a nation just horrendous rates of infant mortality. And so this was put in to hopefully decrease the rates of infant mortality, and it did. However, as a consequence of this, community-based obstetric care that was used in Black and rural communities most often was criminalized. So at that point, because they had these things in place, if you were in a Black or rural community and you did not have access to some physicians, or if you didn't have access to a medically verified or certified midwife, where were you to go? And so many communities, rural communities and Black communities, continue to use their granny midwives, local doulas, and lactation consultants because they didn't have access to that. But the fact that this piece of legislation then criminalized obstetric care, the only obstetric care in many cases that was available to Black communities, this then takes away from our access, if we think about that. If we're wanting to provide people with equitable access to care, these two pieces of legislation did not do that for all people. For Black people in particular, they no longer had access to care. Now, I will say granny midwives and other obstetric care providers continue to provide care to the community for years after this because there was no one else available. The reason why I want to mention those two pieces of legislation is because there has been studies that have shown it is important. Representation matters in so many different ways, but it is really important for Black healthcare providers to be available for Black infants, for Black moms, folks who are giving birth. It's really important that whomever, and folks can see anyone, but we are seeing studies showing that Black infants are experiencing better outcomes when they're treated by Black physicians. And it doesn't mean that they're not experiencing good outcomes with other physicians, but we are just seeing, especially when newborns are having some adverse issues at the time of birth, when they are treated by Black physicians, they tend to have better outcomes, especially when their case is a little bit more medically complicated. And so this is what research is showing. And so we don't know all of the whys behind that, but we do know that there are a number of things that come into play. One of those things being bias. And so I do want to say just really quickly, bias is a normal human thing. We have explicit biases and implicit biases. Those explicit biases are those conscious attitudes that we have towards people or a group or an idea. Implicit biases are those unconscious attitudes and stereotypes and things that we have towards people. And both can be harmful in certain areas, and especially when we're thinking about healthcare. So just to point out how bias can show up in healthcare and it can become a problem. Bias is something that unfortunately is also seen in our medical education. If you go back and read the Flexner report, I just touched on it, but there are some deeper things in the Flexner report that speak to the development of false narratives behind what it means to be an African-American physician. There's a lot in there, so feel free to dive deeper and explore to learn more on your own. But even in a more recent study, as recent as 2016, there was a study of medical students and residents, and it revealed that a significant portion of them believed that there was a biological difference in pain tolerance in Black people. And they stated that they believe Black people could tolerate more pain because their skin is thicker and they have less sensitive nerve endings. Now, I want to reference Dr. James' presentation again. The Genomic Project has already shown we are 99.9% the same. And this thought around Black people having higher pain tolerance is actually very much so inadequate. It's actually false. So it is a false belief that is taught through the medical education. There are biases that are just woven through. Similarly, in 2019, there was a postpartum pain management study, and they found that there were higher odds of reporting pain amongst Black and Hispanic women, but they were actually less likely to receive adequate levels of pain medication. And so when we're thinking about when folks go to and through our medical system to receive care and these issues of bias that come in, and the bias comes from a long history of all the things that we know of around like enslavement and things of that nature. But even if we just think about the policies and practices that have been put into place in the last 120 years, there's a lot of things that have just built upon one another to create these false narratives that have to intentionally be broken down in order to provide the best care for people. So maternal health and bias is a real issue. And then issues with provider bias, we've seen, especially in the past 5 years or so, we've seen a lot of stories come out from celebrities, but for years, women have been talking about issues they've had prenatally during birth and the postpartum period, where they felt like they weren't listened to, or things just weren't taken seriously when they expressed that there was some sort of concern. So not only the history and the policies that are in place, but also those biases that have been built up, unfortunately, due to the history and policies that we see in today. So I bring this social determinants of health graphic back up just to show, we talked a little bit about healthcare, neighborhood, and the built environment, but also speaks a little bit to economic stability and the education. All of these things determine what our health outcomes will be. And all of these things that we see here on the social determinants of health are shaped by our history, are shaped by our policies. And it's important for us to understand those things as we move towards the development of really new and innovative strategies to eliminate the birth inequities and disparities that we see. This will be just one final thing that I bring up really quickly. I like to make sure I mention this in our presentations. Even though we have a lot of proxy measures for understanding the outcomes that we're seeing, but I like to mention that it is racism and not race that is a risk factor. We know that race is a social construct. However, the consequences of living in a race-conscious society are not. Those are real things that we have real outcomes from that. So I just want to point out that it is racism and not risk that is the risk factor, and not race that is the risk factor, even though we use race when we're talking about our data. Just keep that in mind. This is a graphic from Dr. Joy Creer-Perry. I believe she changed this a little from another graphic. And I want to point your attention to the left-hand side. A lot of the times we focus on the disparities we see and the illness and the unhealthy behaviors and the psychological stress. So we talk about like, well, why aren't moms putting their babies to sleep in the way that they know to? But if we really just focused on that, we won't find our answer. We really need to go back to the social determinants of health. And if we think about housing, especially in Akron, and how big of that an issue that is, but not just housing, transportation and job security and all of those different things. If you take it one level further and we look at the power and wealth imbalance within our nation, within our states, our cities, our counties, what is happening there and how and why? And when we look at our historical pieces, how has history shaped some of this power and wealth imbalance that we see? And when we really get to root causes, that's when we're talking about white supremacy and racism, class oppression, gender discrimination and exploitation. Like those are the things that we really are looking to tackle, but often our focus is only on the unhealthy behavior or what is the clinical thing we can do. And to Dr. James's point, we really need to take more of a social look at how we can then begin to unravel some of these things and face these injustices that we see in our health outcomes, and really look at our history, our policies, our practices, our procedures. How has these things happened in the past? Like, how have we gotten here? Why? And then using that knowledge to undo all of this so that we can get to a place where we're actually serving moms, babies, and families across the city of Akron, Summit County, the state of Ohio, and the nation as a whole. And that is all I have for you all. I think I'm right at time, but if you have any questions, I'm open to that as well. Thank you.
Thank you so much, Jessica, and I apologize for pronouncing your last name incorrectly. When my last name was Koger, so I completely understand, and I'm so sorry. But I wanted to allow for any questions right now, if we have any questions. Okay, and we are going to turn it over to the panel discussion, and I'm waiting on Lakeisha to join in, but James Hardy from the Robert Wood Johnson Foundation and Brenda Coulter from The Well are here to speak about the social determinants of health. And so we are just going to take our time and wait on Lakeisha for a second. Just give me 1 second. Okay, so Lakeisha says she's here. Lakeisha, I don't see you though. We were doing so good all day. No, nothing went wrong. Okay. I apologize for the delay. Lakeisha is our facilitator for this discussion, and she is logging in. And we are also waiting on Representative Amelia Sykes. She is logging in as well. So we will be beginning at probably 4:05, I'm hopeful. Thank you. Hello, Lakeish.
Hi. Hi, I
Oh,
made it. Hi.
yes. You made it through the virtual wall.
Good.
Thank you. So this is our social determinants of health and structural and social determinants of health, and how structural racism impacts the social determinants of health. And so if you looked at the way that this program was set up, we did talk about health in the beginning, the COVID-19 and how that's been affected. And during that conversation, Dr. Zavitsky did bring up the social determinants of health. And through Dr. James and Jessica's talk, they spoke about social determinants of health as well. And they also spoke about the structural racism that are in policies. So to close out today's session, I invited Lakeish to facilitate the conversation because she deals with our pregnant moms that are in full-term first birthday at the Zalika House. And then we have our Honorable Representative Amelia Sykes here because she is so passionate about alleviating the social determinants of health during her work in Columbus. We have James Hardy here from the Robert Wood Johnson Foundation. And we also have Brenda Coulter here from The Well. And James and Brenda do exceptional work around housing and workforce development and working towards assisting moms and Black women in particular mitigate through housing and workforce development. So I wanted to turn it over to Lakeish, and the floor is yours. Thank you so much.
Thank you, Tamika, for having me. It's an honor and a pleasure to represent Project Ujima on this platform. So I appreciate your patience as I was having a little bit of trouble trying to get in here. So we're cheated out of our time, but I think we can still have some robust conversation. So I appreciate all of you and the work that you do in the community. So I'd love for you to just share a little bit about some of the social determinants of health and, in your opinion, the impact it has on infant mortality. So I'd love to start with our Representative Amelia Sykes. Thank you.
Hi, Lakeish. Thank you so much for letting me start. And thank you, Tamika, and everyone who put this together. Let me first say I am not actively driving. I am parked on my way to Columbus at a gas station. I just haven't taken my seatbelt off because really, what's the point? I'm going to jump right back on the road here. But this topic of social determinants of health is something I spent a lot of time investigating and challenging my colleagues to consider as we look for ways to mitigate our infant and maternal mortality crisis here in Ohio. And I know you all have heard the definitions, and so I'm just going to jump right into the work that I have been pushing, which is essentially to address the needs that women and families need in order for there to be an environment in which infants can survive past the first year and women can survive through their pregnancies and childbirth. And so two very important and specific issues I've worked on are one, increasing the minimum wage, and two, making a refundable earned income tax credit. As you may know, I have a master's degree in public health, and one of the things I did when I was in graduate school was worked with an organization called the Institute for Child Health Policy. And two of the researchers there did some studies on if you increase the minimum wage, infant mortality goes down. If you make the earned income tax credit refundable and you increase that, the infant mortality rate goes down. Now, that is not a causation relationship, it is a correlational study, but essentially it is when you stabilize a family structure and allow them to have access to economic opportunity, their immediate surroundings completely change and allows for there to be an environment in which a baby is healthy. So that means that they are living in a home that does not have much lead mitigation or none, or they have the ability to do so, or they have a car or transportation to get them to their doctor's appointments. They're living in community that they feel safe. They're living in a home of some sort, whether it's an apartment or a house, that they don't have to worry about if they're going to be evicted or they're couch surfing or one of these other issues. And so having those financial resources and knowing that the Earned Income Tax Credit, for example, is the most effective anti-poverty program in the entire country, and making sure that it is refundable is important. Now, in Ohio, the minimum wage is a little bit higher than the federal because there is a constitutional amendment, but it's still just barely over $10 an hour, which is not enough money to pay for a 2-bedroom apartment in this state or any other or most states in the country. And we do have a Earned Income Tax Credit at the state level here in Ohio, but it is not refundable. And so 2 things that I have been working on is increasing the minimum wage to $15. It has not been met well because a lot of people do not believe that that is an important thing to do for a lot of different reasons. We can get into it if we have time. And unfortunately, there is a policy bend here in Ohio that prefers to give more money to the highest wage earners rather than those who need it the most, including our single family parents or low income families who could use that extra cash infusion. But thankfully, the child tax credit from the federal government is around, which is helpful and can fill that gap until we do better here at the state level.
Great work. I mean, I am impressed with that. I guess I wasn't aware. So thank you. Thank you for your work at that level. I'd love to bring James Harding into the conversation. If you could share a little bit about some of the social determinants of health and the work that you're doing and how it affects infant mortality.
Absolutely. Thank you so much. And it's a privilege to be with you. So I have the honor to work for the nation's largest health foundation, or health focused foundation. And in particular, I work in the healthy communities section, and we work really at the intersection of place and health. And so we believe strongly, as everyone on this call, I think, believes, that where you live should not determine your health and well-being outcomes. And we also know that things like healthy food, quality schools, stable housing, good jobs with fair pay, safe places to be with community, and that can come in the form of parks or walking trails or just safe sidewalks, all contribute to our health outcomes. And as many of the panelists have done way better than I could, we have a long-standing history in Akron and Summit County, in Ohio, and in the nation of systemically keeping certain folks out of communities that have those opportunities. And so we work in the space of trying to change that paradigm at a national level. But I think just focusing in on housing for a moment as a key determinant, that's something we're very focused on. And I have the opportunity, even in my 4 short months, I'm a newbie there to start to get involved with. But I wanted to share with everyone some pretty startling statistics, and it builds off of what Leader Sykes just talked about. So we are missing in the United States, we are just missing 6.8 million units of housing that is affordable to the lowest income residents in the country. They just don't exist. They're not being built. And when they are built, they're built in many of the same structurally racist patterns that we've seen over our history. So they concentrate wealth, they don't offer opportunity or mobility. And in Ohio in particular, we're missing 242,000 units of affordable housing. Unfortunately, we don't have data or I don't have data readily available for Akron and Summit County, but I'm putting in the chat 2 links to a grantee that we have, and I've had a chance to work with the National Low Income Housing Coalition, and they really focus on the supply issue and the wage issue. So this, building off of what Leader Sykes talked about, there is a huge gap between what it costs to rent, let alone own, and what people make. And so as a result, a market rate apartment, this is 2020 data, so it has some pandemic in it, but a market rate apartment in the United States is about $1,200, about $1,300 in between that. A family of 4 living at the poverty level, they can only afford an apartment for $663. The median rent in Akron is $759. So even though we're super affordable from a standpoint of home ownership, we are not affordable when it comes to renting. And that's the way in almost every city in America, small, medium size, and large. And so when we extrapolate that out and we look at how many folks, our fellow neighbors and citizens are living in poverty in the city of Akron. That's 23%. That's about 45,000 people who fundamentally cannot afford housing in the city of Akron. And so, to Leader Sykes's point, there is a structural and institutional problem that isn't going to be solved without probably new ways of thinking, new ways of working, new programs, new laws, new incentives, all of those things to try and get at the issue if we really want to move the needle that housing is a basic human right, which I think a lot of us believe.
Thank you, James. Thank you. Brenda, same question for you. We'd love to hear your perspective on the correlation between infant mortality and social determinants of health.
Well, when I first think about it, I think about toxic stress as being like the major and top component, or stress in general, of what our moms experience in their day-to-day lives. So working with the well, we get to identify some key components of what can contribute to that stress, and then find ways to alleviate those. So even in continuing the conversation that Mr. Hardy is talking about, when we talk about housing, and the well was primarily a community development corporation. We wanted to develop affordable housing, but in getting people into housing, we started to realize, well, how do we move people from just surviving and into that thriving mode where we're getting jobs that they can enjoy, so that, again, what you do for a living and what you do for work can impact your entire life. It can create stress, it can alleviate stress. So the key about this program is that it works to identify what the participant wants to do. What do you love to do? How can we move you into your desired career pathway, so that as you're going to work, it's more than just a job that you're going to, it's something that you actually love and would like to do. So it speaks kind of to each of those points of the social determinants of health, because we are building communities in our cohorts. These are groups of women who are coming together, and they're learning about each other, and they're realizing that they are not alone in the experiences that they've had. Also creating that economic mobility into stability, and understanding that it's a process, and utilizing the cohort process as not only determinant of let's get you into this work, but let's keep you into this work, and identify mental and emotional barriers that may exist with these moms as they go into the program. So when we came into partnership with the Summit County Public Health on their full-term first birthday, then we realized in essence, as we help mom and as we wrap our arms around mom and we reduce her stress, then that then creates an environment for the infant to be able to thrive, whether it's the infant that she's pregnant with or as we're moving up to that 1 year mark. So it's just an understanding that we can work to alleviate this learned hopelessness that a lot of moms have experienced through poverty, with this neighborhood-focused, trauma-informed approach to career development. So it's just a little bit different than most programs.
I like that. I like that. And so I was doing a little bit of research on social determinants of health, and I came across this new, I think it's a new term for me, structural determinants of health, right? And so I think Leader Sykes kind of alluded to a lot of some of the structural determinants of health that she's doing at her level. And I love that you're starting with the wage gaps and the salary gaps, right? And so I'm thinking about, like, at a community level, like, what are some of the additional things that we need, especially as it relates to infant mortality or infant vitality, that we can be focusing more of our attention to? And I would offer that question to anyone who wants to jump in.
Well, I can start and say, I'm going to piggyback off of what Brenda said, and eliminating the toxic stress that particularly impacts women of color and Black women. And so I know I focused my original comments on wages and economics, but quite frankly, one thing that we know about infant mortality and maternal mortality is it does not discriminate based on your socioeconomic status. That Black women, no matter if we are CEOs, we are tennis players, we are pop stars like Beyonce, or we're teachers or project managers or janitors or home healthcare workers, we experience racism in the communities that we live in that changes our physiological structures and does not allow for us to live our best and healthiest lives. And that translates into what happens to our babies. And so as a community, we have to and must recognize those places in which there are biases that are built in, from whether it is the inner belt, like where that I take all the time getting home, or it is the way that you communicate and engage with Black women when they access healthcare services or public services that either encourage them or discourage them from coming back. And so this becomes the work of people who are not of color. And I always like to say that it is not, in fact, racism that is a health factor. It is exposure to racism. And this work is going to be primarily focused on and needs to be done by people who are the beneficiaries of privileges that others don't have. And so that means white people, y'all. So clutch your pearls if you need to, but that's the reality here. We need you to be co-conspirators, not just allies, in eliminating this, because we know that these indicators of infant and maternal mortality also mean that people look at our communities and say something is wrong there. When we have numbers as high as that we do, people can say something is wrong. I may not be able to put my fingers on it, but there are inequities and problems there, and we don't need to have that. So for the benefit of all of us, we need to engage in some serious work to eliminate racism in our structures. And in a community like Akron that I know is so close-knit and collaborative, we can do it here and be a model for others, so they can look at us and say, we should do what they did and eliminate these disparities so our Black babies and mothers can live.
Thank you. Thank you.
I think for me, I consider accountability to one another and to not forget who we're developing the relationships with. I know that there are so many people. We have some great political representatives, such as Emilia Sykes, who's amazing in this fight, just watching her fight, but in also understanding that there are people who need our help, who need our assistance, and who need our advocacy, and to make sure that we're all holding each other accountable in this community service field to make sure that we are providing the best services available and making sure that the services are on par with the needs of the people whom we're serving.
Thank you. Thank you. James, did you have a response that you want to jump in here?
I mean, it's hard to follow both of those. That was amazing. I agree with everything that's been said. I would only add and maybe put an exclamation point behind the need to move beyond just bringing equity to our policies to bringing an anti-racist view to our policies. It's to what Leader Sykes said. It's not enough just to say, which I think many of us in the majority are prone to say, which is, I'm not racist, I don't see race. That's terrible. And we need to actually go beyond that and be actively looking at ways in which we can repair, we can heal through policy and action, and also to get out of our comfort zone and recognize that there is not, we don't have to operate from a place of scarcity. Oftentimes I get the sense that folks that look like me sometimes think that, well, by making it better or repairing past harms or by being more equitable, somehow you're going to lose something. That is patently false. And it really divides us. And it creates a situation where instead of banding together and looking at the systems and structures that are really impacting all of us, we end up keeping those in place to benefit ourselves. And so it's got to go beyond, as both my colleagues have said, go beyond just simply saying, well, I'm not actively doing anything wrong, to saying I'm going to actively do something right.
Mm-hmm. That's good. Thank you. Thank you. So I heard that there's some work that our community can wrap their arms around, starting with places that biases exist and the engagement that kind of happens within the healthcare system. I heard you, Brenda, when you said accountability. We hold one another accountable, especially those in position who have the platform and can use the platform to affect change, right? So we are getting close to our time. So I do want to leave a few minutes for any other thoughts or ideas that we wanted to share around infant vitality and maternal morbidity with our audience here. Any other remarks? Sure, go ahead.
I'll never mind sharing. I just want to focus on the importance and remembering that it is so very important that we build relationships. We are building relationships, and there's a trust factor that needs to be won back from people in our positions who do have this platform. We need to win the trust of the people that we are trying to serve. And it's very important that we make that a priority in order to actually effect change as we move forward.
And I would add by saying you have to listen to the people who are having experiences. And when they tell you that things are not going the way that they should, or that you think that they should, listen and hear them out before you immediately reject it as not true. Because often in these conversations, whether it's accessing care or certain services or experiencing racism, it's uncomfortable for the person who is hearing it on the other side. If we're criticizing your healthcare system, or we're criticizing your office for not providing care, we're just talking about what privilege looks like for some groups or others, people get very defensive and they don't want to hear it. But I just challenge people to say, in that moment, in that 5, 10, 15-minute conversation that you feel uncomfortable, just sit there and sit there and think about how bad that is for you. But if that is your experience every single day, or every single time you interact with someone who doesn't look like you, that is far worse. And so use empathy in your interactions to recognize these stories that people and women are sharing are true and are real and deserve your thoughtfulness, and not your immediate dismissal simply because that discomfort in the moment is something you want to experience. I assure you, the racism that I experience every day is far more challenging than that moment when someone calls you out on it. And so allow us to share that with you and talk with that through you. And if we are passionate or loud or angry or cuss, it's okay. We are allowed to have that. It's hard to take it on, and you might be the person that is on the receiving end of it. Right. And let me just go ahead and apologize for everyone and say it's not personal, but it is hard to shoulder those burdens. And when we share these things with you, we're sharing it because we want to make it better for not only ourselves, but other people who we don't want to also have those experiences.
Thank you, Leader Sykes. I appreciate your perspective and really just laying it, making it really clear. I appreciate your work at the structural level. And then also James and Brenda for your work that is a direct result of some of the structural determinants of health. And so I thank you so much for the work that you do. Stay in the fight. Stay in the fight. We really appreciate you. Tamika, do we have any questions for our panelists?
We don't have any questions, not even on YouTube or on the Zoom. So I just want to thank you guys for the authentic conversation today. It was very authentic and needed for the community. And this will be a precursor to what we will talk about next year's Health Equity Summit. So I just wanted to say thank you, Leader Sykes, for pulling over and participating in this panel. Thank you, James. Thank you, Brenda, and thank you, Lakeisha. And thank you for all of the work that you guys do for our community here in Akron and Summit County. It is, it is a lot of hard work, and we all know it, and we are all in it together. And I want to thank everyone on the Zoom and on YouTube for joining in today. And we will see you guys again tomorrow at 1 o'clock. Thank you for your time. You all have a great evening. Bye.
Thanks.